and thank you for the suggestions and comments, Dr. Halkitas. If there are no other
I had a quick
questions.
question.
Hi.
Dr. Mortimer Moxie on Com Health.
Hi, Dr. Moxie.
The question was, I noted you said that some of the women could not access radiation therapy. Why would that be, when we have a radiation therapy center here?
Correct. So it's
Is it the
not
cost? Is it
the
what?
physical access to it. It is the financial limitation of the
Oh
patients.
boy.
Yes.
That is sad. No way. That shouldn't be in this day and age. Can't they get support from health social services or
Dr. Moxie, can I interject here?
Sure, please.
Sure.
That's an ongoing issue. There have been attempts to make it more accessible, but it's set up that there has to be some contribution from the patient in receiving radiation care, right? And there's, at least I recall, I don't know if it's changed since I was there, that you must make some kind of down payment and a payment plan, and that initial down payment is not the full cost of your treatment. That's the initial payment. Depending on the planning and whatever else needs to be done for you specifically, that bill can escalate. And yes. I think, I think we get there is this belief that that payment that you make is the payment, and it's not. So it's a cost issue. And I don't know how else social services can assist with that. But there's a payment plan associated with it. But it is what it is. It is what it is.
I also learned yesterday that the Ministry of Health has a fund for catastrophic care.
Yes, they do have a fund. But I mean, I don't know what the criteria are to I think it started out as about $10 million in that fund. And if you know anything about oncological care,
yes,
that $10 million isn't a lot. One person can spend that. Can require that amount of money for treatment and care. So, I don't know what their criteria are for selecting the patients who get access to it. But I know the fund does exist. Yes, it does exist.
But this brings in an ethical question. Why should some people not get radiation therapy that is almost within walking distance of the hospital?
Yes,
because
I totally understand. I don't think this very nice discussion, Dr. Moxie, but this is like beyond the scope of this particular forum. We have to have a
but it's something that needs to be looked at.
Jump into the government. Yes. It's
totally
a
agree.
Good
totally
generate a good discussion. Thank you very much, Dr. Bodhi. I'm assuming that considering for your second study, because I see the sample size is little smaller, just because of your time in the program. So I really encourage that your department or you would be the Prince PI and continue this study. Thank you very much. I'm going to invite.
I had a question. This is Dr. Hannah.
Dr. Hannah. Okay, quickly.
Yes, ma'am. No, she mentioned that, Dr. Bodhi, great presentation. You mentioned that in 2018, there was a decrease in breast cancer, and I was trying to figure out.
There was a spike.
If you know why? Why was there a spike or an increase? And the other question that I had also was related to, are there any studies that are being done on breast cancer with several Caribbean countries, including the Bahamas? Are there any studies that we have that has been done recently or in the past? Thank you.
So that spike, I think, actually was the general trend that was going up. And if you remember, shortly after the following year, in terms of the access to health clinics and whatnot, started to close because of the incidence of COVID-19. So as I pointed to the tail end of that graph, it looks like there may be an up spike coming back again. And I think that's just the resumption or patients returning to clinic. But no, we did not look into the specifics why that year it had escalated in 2018, but I'm just assuming that was the general trend in terms of the incidence of breast cancer, not in terms of if there was any identifiable environmental or genetic reason why that spike happened. With regards to your second question, can you repeat it, please, about research in the Caribbean? Dr. Hannah?
I think.
Yeah, I was asking about the study, any studies being done by Caribbean countries, which include several different nations, like a widespread study showing why there's cancer, what's the reason for the cancer or the increase in breast cancer in patients who, let's say, in the Bahamas, in Dominica, in Jamaica, several Caribbean countries. Are there a widespread study?
So there are studies, Jamaica and Trinidad from our last Caribbean College of Surgeons conference that have been looking into breast cancer, but in terms of the specifics as to why it's happened, no. We have a colleague who has actually looked into the genetic distribution similar to our study, where they noted in terms of their prevalent gene is the PLAB2, but not in terms of environmental factors otherwise, but only looking, I think the direction is going towards genetics generally in terms of why we're having increasing rates of breast cancer throughout the Caribbean. So it's really genetics that the studies regionally are looking at.
Thank you, Dr. Bodhi. I didn't really see it, but Dr. Halliday alluded that Dr. Singhvi had her hand up, and Dr. Singhvi, can she finish her quota of questions? But I will allow Dr. Singhvi to ask her quick question, please.
Mention that, I think we need for persons not to need so much funding, radiation therapy. When we look at dialysis, they're not asking for that kind of deposit. And these persons are having dialysis basically for the rest of their life. Most of these patients are requiring treatment for chemotherapy or radiation therapy for cancer. It's for a finite period. And I think we need, as a community, to advocate for a better funding mechanism. And even though they may need to donate to their care, I think when you look at them to come up with half of the fund, and in some cases, I think it's $7,000-8,000 that they are asking for radiation therapy. Most of them are not going to have that. And what you have, which is a treatable, curable disease, they are not able to get it. And this is also, even for chemotherapy, they're asking them to come with significant funds. I think we need to add that the amount that they're asking for needs to be much less. They're not doing this for that. Thank you very much.
I agree in terms of that is the reason for a lot of patients in terms of their access to adjuvant treatment. It's what's, I think, the cost that they're asking patients to put down, even as their down payment, the average Bahamian oftentimes does not have to give. And so that causes us to overtreat in terms of surgical options for patients. So who would or may benefit from a breast conservative surgery end up with a mastectomy instead. And it's because we don't want that early breast cancer to develop into an advanced breast cancer, especially when they cannot financially access the adjuvant treatment options, why we act more aggressively in terms of surgery. Thank you for your questions.
I had one quick observation, please, moderator. The question of the spike in 2018, would that have been related to like an emphasis on mammogram screening? Were there any big campaigns? Because women, react to that, they respond. and they'll go in groups and sort of have mammogram parties and all this kind of thing. So would that was there anything happening at that time to that it could have explained that spike? You know, in other words, was it really a true increase in incidence, or was it just situational?
Again, that was a bit beyond the scope of the study. It may
True.
have just been situational, so I'm not sure the exact details.
Okay, sure.
Hello, hi. Good afternoon. Sorry, I think I remain muted. Moderate the host. Can you please keep me unmuted for some time? Good discussion. We do have the topic which is similar to following. So at least I'm assuming that we'll have a little bit of difference in the ethnicity. And this next topic is brought by Dr. Bianca Edgecombe. Again, we always feel proud when one of our just comes and present. She has done her post-graduation in radiology from Trinidad. She's the recent graduate from that program. I am not very sure she has started working in PMH as yet or not, but definitely she will. And she has a very interesting topic addressing the genetic or the density differentiation in different ethnic population about the breast cancer again. Thank you very much, Dr. Bianca Edgecombe. Welcome, and you can start your presentation. Thank you.
Thank you. Yes, I've been back for 3 years now, actually. Okay, can you see my screen? Hello?
We can see your screen.
Oh, thank you. Good afternoon. I'm Dr. Bianca Edgecombe, an outline on talk, my research entitled Breast Cancer and the Risk Factors in Multi-Ethnic Women Presenting for Screening Mammogram at San Fernando General Hospital. Here is an outline of today's talk. Breast density reflects the amount of fibrous and glandular tissue in a woman's breast compared with the amount of fatty tissue in the breast, as seen on a mammogram. High breast density can make it difficult to detect abnormalities during mammograms, and so women with high breast density have an increased risk of breast cancer, making awareness crucial. Density can vary between individuals and even within the same person over time. It's often influenced by hormonal changes such as age, lifestyle, and it can also be different in different ethnic groups and different geographical areas. So knowing breast density can lead to more personalized screening recommendations for better health outcomes. The impact on mammogram accuracy positively. Advancements in imaging technology allow for improved accuracy in detecting cancer in dense breast tissue, reducing false negatives. Educating patients about breast density can increase awareness and prompt proactive health measures, potentially leading to early interventions. Negatively, higher breast density can mask tumors during mammograms, leading to false negatives and delayed diagnosis of breast cancer. Women with dense breasts may require additional imaging tests, which can increase healthcare costs and lead to anxiety. Current mammography guidelines may not fully address the needs of women with dense breasts, resulting in inconsistent screening practices and potential oversight. Study rationale. The study was undertaken in Trinidad, which is of a diverse ancestral background, and data on ethnic variations of breast density, particularly those of Caribbean origin, is limited. Breast density being an independent risk factor for breast cancer, it will serve the women of Trinidad as well to have data about the typical appearances of breast on mammogram in this multi-ethnic population. Knowing the prevalence of dense breast in this population can assist not only radiologists but also primary care physicians and women in the fight against breast cancer. So the hypothesis was that there are differences in breast density among a population of women of different ethnic backgrounds in South Trinidad. The aim of the study was to provide an assessment of mammographic density among multi-ethnic women in South Trinidad presenting for screening mammogram at the San Fernando General Hospital. So my objectives were to determine the prevalence of dense breast in the screening cohort, to determine if there were variations in mammographic densities based on ethnicity, to associate common risk factors for breast cancer with mammographic density, to determine if there were any inter-reader variability with the visual assessment of mammographic density, and to determine the adequacy of current screening modality for this population. The study design. The study was a cross-sectional retrospective study. It was done with review of mammogram reports of women presenting to the San Fernando General Hospital for screening with a prospective interpretation of a subset of mammograms. Studies database was generated from the San Fernando General Hospital's Picture Archiving and Communication System, or PAC, for a 3-month period from July 4th, 2019 to October 4th, 2019. So, asymptomatic women presenting to the San Fernando General Hospital for screening mammograms during the study period, greater than age of 40, with no personal history of breast cancer or prior breast surgery.
Sorry to interrupt you, Dr. H. Can you do something to your mic? I think your voice is not as clear as it should be. And then you can continue.
Okay, give me a minute.
If it is too difficult, you can restart. Where all of us can just, start wherever you were in the presentation. We all will increase our volume a little bit.
Okay. Hold on. Hello. Can you hear me well? Better?
Yeah, we can hear you.
Okay. So informed consent was obtained from all participants according to the Institutional Review Board approved protocols, the University of the West Indies, St. Augustine Campus Ethics, and the Southwest Regional Health Authority Bioethics committees approved this study, and all participants provided verbal consent for their demographics to be used, which was recorded on a consent form. So the breast density categories explained. So breast density was recorded using the BIRADS, the Breast Imaging Reporting and Data System, the 5th edition. The breasts almost entirely flatly seen here. That's category A. Category B, scattered areas of fibroglandular density. C, heterogeneously dense, which may obscure small masses. And D, extremely dense, which lowers the sensitivity of mammograms. So consultants use this method to report the categories on the patient's reports. Methodology. So the study sample included 2 standard mammographic views per breast, a cranial caudal, and a medial lateral oblique taken on an analog Siemens MammoMac 3000 Nova system. All images obtained were sent to a picture archiving and communication system, PACS, reviewed on an Osiris DICOM viewer, and every woman had a single breast density category using the BIRAD's 5th edition, which was assigned based on readings from both breasts. And this was recorded on reports. And a randomly selected sample of about 10% of the mammograms were independently read. Sorry. Reports of all participants were retrieved and breast density categories recorded by a department pre-screening questionnaire. The following variables obtained included the patient's age, history of prior mammograms, menstrual history, and family history of cancer. Participants were contacted via telephone within 3 months of their department mammogram and asked to provide information on their breast cancer risk factors, such as body mass index, which was calculated using their self-provided weight and height, and self-identified ethnicity, parity, breastfeeding history, and exogenous hormonal use were included as covariates were not routinely collected. So statistical analysis. So data was statistically analyzed using the statistical package for the social sciences for the SPSS software version 26. Descriptive analyses used for the distribution of characteristics were presented using frequencies and percentages of all categorical data. Chi-square and analysis of variance or ANOVA statistical tests were applied to assess differences between ethnic groups and breast density. Multiple logistic regressions were used to explore the relation of ethnicity, body mass index, reproductive factors, and family history with mammographic densities. Pearson's correlation coefficients or odds ratios were used in assessment of the strength of the data obtained. The agreement between observers was assessed using the kappa statistics, and a level of significance was set at p less than 0.05. So of the 650 women presenting during the study period, 3-month study period, 319 were eligible for this study according to the inclusion criteria. Women were excluded from analysis on the basis of age less than 40, indicating having previous breast surgery, personal history of breast cancer, non-screening mammogram, i.e. for a breast lump, mastalgia, or discharge. There were a certain amount of missing request cards. 4 women refused to participate in the study, and after several attempts, some could not be reached via telephone. So a total of 236 women were enrolled in this study. All subjects enrolled in this study were stratified on their self-reported ethnicities. East Indians made up about 57.6% of the cohort, or 136 women, followed by Afro-Trinidadians, 30.9% or 73 women. Mixed represented 10.6%, 25 women, and a small percentage identified as other. So demographics by ethnicity, the ages of participants enrolled range from a minimum of 40 years to a maximum of 85, with a mean of 57.6 years. 15% of the patients were between 40 and 49 years. The largest group was between 50 and 59 years, 45%, 33% between 60 and 69 years, and 5.9 were those greater than 7 years. More than 2/3 or 67% of the women were overweight or obese with a BMI greater than 25 kilograms per meter squared. The overall mean BMI of the cohort was 28.5 kilogram per meter squared. 79% of the women, 187, were postmenopausal, with 21% being premenopausal. The mean parity was 2.6, and 188 women said that they had breastfed. 9% of women reported a family history of breast cancer, which meant a first-degree relative, either mother, sister, or daughter. Overall, 96% of the patients said that they did not use exogenous hormones, and there was no statistical significance among demographics by ethnicity. So breast density by ethnicities. Overall, there were 56 women with almost entirely fatty breasts, as with category A. The most recorded category was B, scattered fibroglandular densities, 112 women representing 47.5% of participants. 57 women were recorded in the heterogeneously dense category, that's 24.2, and 11 women were categorized as extremely dense. This meant that women with mammographically dense breasts, categories C and D, sorry. Right, so this meant that women with mammographically dense breast categories C and D comprise about 28.9% of the sample. Associations of breast density and ethnicity to test whether the density was dependent on the ethnicity or not, since both variables were categorical nominal variables. A two-tailed chi-square test was computed at the 0.05 significance level. The results show that the chi-square equals 1.95 with a p-value of 0.58. So given that the p-value was greater than 0.05, the null hypothesis was not rejected, and it was clear that there was not enough statistical evidence to support the alternative hypothesis that there are differences in densities depending on ethnicity. So therefore, it can be said that breast density was not influenced by ethnicity in this group. Associations between breast density and other risk factors. So the third research objective sought to determine which risk factors for breast cancer contributed to mammographic density. To achieve this, the independent variables considered were age, BMI, ethnicity, menarche, menopausal status, number of years breeding, parity, age of delivery, breastfeeding history, family history of breast cancer, and exogenous hormone use. So the relationship of these predictors with breast density were explored with a series of logistic regression models. The major predictors of breast density were age with an odds ratio of 0.876, p-value of 0.4, and BMI with an odds ratio of 0.66. So this was further explored using ANOVA, and again, both variables were found to be significant determinants of breast density with p-values less than 0.05 for age and BMI. So the results show that the average age for those with low density was 58.9 years, and this average age was higher than those with higher breast density with a mean age of 54.4 years. So this meant that increased breast density, So this meant that increased density was associated with younger age. And regarding BMI, the average was higher for those with low density with the mean of 29.16 than those with higher density with a mean BMI of 26.8. So using the BI-RADS fifth edition to assign breast density is a subjective assessment, and we know that there are more accurate ways of assessing breast density by using either computer-aided software. So the fourth objective was to assess inter-observer variability, and two consultants with more than 10 years experience were blinded to the women's clinical characteristics as well as the other person that was reading. And so the inter-rater reliability was a kappa of 0.81 with a p-value of less than 0.05. So this meant that there was a strong level of agreement. So the study limitations. So this study was undertaken at a single public institution, which introduces selection bias. This meant that women residing in the southwestern region of Trinidad were most likely to be included. 15% of the files were missing, and so those women could not be classified or contacted if inclusion criteria were met. Those who refused participation and simply could not be reached was close to 30% excluded population, which further led to a self-selection bias. The information on confounding variables was self-reported, and thus information bias could be introduced. No long-term conclusions can be drawn from this study, as there was no follow-up of patients relative to risk factors for breast cancer, breast density, and the development of integral breast cancer in any of the ethnicities studied. So in conclusion, the breast density is a significant factor in mammography. It can obscure tumors, making detection challenging. The prevalence of mammographically dense breast, C and D, in the participants in this study was found to be about 29%. No statistical difference in mammographic density when comparing the ethnic groups represented in this study. Significant associations of mammographic density with age and BMI were noted. Inter-observer variability was found to be minimal for radiologists, indicating a high level of agreement and confidence of categorical assignments of reporting. And due to the low mammographic density profile, screening by mammography can be considered as an appropriate early detection imaging modality due to its sensitivity in the detection of breast cancer in this population. I'd like to thank you for your attention.
Thank you, Dr. Edgecombe, for for presenting your research, and my apology for not keeping up with the information. Welcome to the Bahamas. I know. All right, so I'm opening the floor for Dr. Edgecombe.
Dr. Ed.
Hi, Dr. Hannah here. Dr. Edgecombe, great study. In terms of these patients, what is the comparison with your study compared with other global study of a similar relationship? That was one question I had. And the second question, does the any bias play into this study, given that operator bias, does that have any play in the study as to the density of the breast? Those are my two questions. Thanks. I'll listen.
Okay, I'll answer the last one first. So that was one of the objectives in doing, because it was a retrospective study, just taking a sample of those particular persons and having the consultants reread them again and being blinded. And so that was where you saw me talk about the inter-reader variability, because we know that different person, it's a subjective thing. So it's a visual method, whereas the computer might give a more accurate one. This is subjective based on how you perceive the breast density to be. So that was the reason in actually asking the consultants again to read it and see how well, if you read this again, would you always give it an A? Would you always give it a B? In terms of other studies, so it varies. So like I said, based off of geographic location, breast density can vary. So in the Chinese population, they found that they tend to have more dense breasts. Now, it could be because they are generally have a smaller BMI than more Western women. And it varies in the US as well. So most of the Eastern women tend to have more higher breast density than those on the Western side.
Thank you, Dr. Edgecombe. Like, if I remember correct, maybe 10 years ago, a similar kind of breast density study was conducted right here by Fort Terrace Diagnostic Center. And it's from my memory. I can't really remember exact figures, but it did hover around 30-35% in our population too. So that was that study. But thank you very much. And I'm just assuming if nobody has any question, then I can invite the next person.
Just one comment, please, Dr. Burunda. I thank
Go ahead, Dr.
Tom for presenting her study. And I would like to see this as a continued trend, that all of our returning persons who have done research as a part of their postgraduate experience, that they are able to share their studies with us. So I thank Dr. Edgecombe tremendously for taking up the offer to do so.
Thank you.
Thank you, Dr. Singh. I think I have two hands up. Can you guys please do it quick? It's Dr. Moxie and Dr.
Yes, quickly. Yes, Dr. Edgecombe, what do you see as the role of artificial intelligence in your field of radiology? And in relation to this study where, you said there wasn't much radiologist variability, but there's been talk about that artificial intelligence.
Well, it's helpful. You'll still need a human eye because the computer picks up a lot of things, and so you have to weed out what is true and what is not true. So in terms of detecting calcifications, it's very helpful in that regard, particularly for breasts. For the inter-observer variability, what I was speaking about earlier, sometimes categories B and C tend to be a little gray area for radiologists. So it could be helpful in that regard as well.
Thank you.
Thank you, Dr. Hcom. I am trying to figure out who is my next speaker, because in my list there is a resident from Grand Bahama, Dr. Dennis Cuano.
Yes, ma'am.
You are there?
Yes, ma'am.
Great, thank you very much. So Dennis Cuano is a resident in Grand Bahama, Rand Memorial Hospital, and he is presenting on using MS Access as a tool in creating electronic medical record system for low resource communities, focused on improving healthcare infrastructure. Dr. Dennis, welcome. You can start.
Thank you, ma'am. Can everybody see my screen? And am I coming across clearly?
Yes.
No. Okay. Okay. Let's start.
Yes, please go ahead.
Okay. This is a comparison of the turnaround time between electronic medical record systems versus paper-based documentation. It shows higher chart retrieval rate, lower errors, and better legibility compared to paper-based record keeping. However, it comes at a cost, pun intended. The annual cost of a simple electronic medical records is about $13,000. Some systems cost more with annual subscriptions per provider. Is there a less expensive alternative to commercial electronic medical record system? Good afternoon. Today, I'm here to present the topic, using MS Access as a tool in creating an electronic medical record system for low-resource communities. I have no conflict of interest to declare. Healthcare systems around the world are driven by constant flow of data that comes both from patients and the healthcare workers. Data that is available at a moment's notice leads to better and timely care for patients with evolving disease process. With the digital age, record keeping in healthcare has developed in nature. Paper and ink are replaced by ones and zeros, and light-speed transmission of data and orders. Due to various situations facing many countries around the world, there is a clamor to shift from paper-based documents to digital entries. Hurricane Katrina in 2005 made this apparent when untold number of records was left inaccessible in the aftermath. Closer to home, the East End clinics in Grand Bahama lost all their records when the clinics were destroyed by Hurricane Dorian. Admittedly, a distinct disparity exists between developed and developing countries in the use of electronic medical records. Developed countries have better access to the technology and infrastructure to support this approach of digital record keeping. At the other end of the spectrum, developing countries lack the necessary support to implement such changes. The cost of setting up electronic documentation, technical support, and the cost of maintaining such a system are challenges to low-resource localities. Additionally, there is always the constant threat of civil wars, natural disasters, and epidemics, which leads to a very inadequate healthcare delivery system. An electronic medical record is the digital record of a person's overall encounter with the healthcare system. Depending on the type of system employed by the healthcare institution, data can be as minimal as to just the essential visits or can be as robust as a comprehensive health status of the patient that may include all visits, laboratory results, treatment plan, and medications. Using electronic medical records have many benefits. The use of electronic medical records reduces the potential for medical errors. Some electronic medical record systems have a way of detecting potential drug reactions, allergies, as well as check for proper spelling and dosing. This reduces the risk of misspelled or inappropriate drug dosing because it will do away with physicians writing the orders by hand. This also brings about better documentation. Some clinical information systems do not allow the system to proceed to the next phase unless all required fields are filled with the appropriate entries. With proper documentation and reduced confusion due to ambiguous orders, there is an increased efficiency in the workflow, thereby reducing cost and time spent looking for missing charts. Referrals between specialties are also seamless. All these increased efficiencies translate to better patient satisfaction. In addition, there is a wealth of data that can be obtained from an electronic database. Reporting is easier, as well as health trends can be gleaned from the records. Logistical support and resources are better distributed because of this. This is especially true during calamitous events that need rapid response from healthcare authorities. We are all too familiar with this kind of photo. The physician's handwriting is the bane of written orders. However, electronic health records are not absolute and also carry some unique challenges. The initial potential cost of the system is the main barrier to implementation. The costs cover hardware and software procurement, training, infrastructure, as well as manpower to maintain the system to keep it running properly. The electronic medical record system software should match the computer hardware used in the institution. Incompatibility issues also arise from transfer of data between institutions using different systems. Another issue with electronic record keeping system is the limited technical knowledge of the end users. Traditional healthcare workers are hesitant to adapt to the new system due to the fear of erroneous data entry. Implementing the new system can also initially disrupt the established workflow. One of the options to circumvent the above barriers is through the use of MS Access as a simple relational database management system. Its simplicity of setup, customizability, and minimal maintenance make it an attractive option, especially in primary healthcare in low-resource communities. MS Access is part of the Microsoft Office suite, along with the more familiar MS Word, MS Excel, and MS PowerPoint. MS Access has several features that make it a good option for a database. First, it allows for multiple users to access the same file at the same time. As much as 255 users can access a file simultaneously. Permissions can also be customized to give access to specific portions of the database depending on who the user is. This will prevent alteration of data and will secure the file of the organization. MS Access also has a shallow learning curve that makes it possible for beginners to design and maintain the system. But MS Access also has a number of disadvantages. First is the limited storage capacity. The whole database is only limited to about 2 gigabytes of storage. However, for most needs, this is enough for 350,000 to 500,000 entries, depending on the number of tables and the number of fields in each table. Another disadvantage of MS Access is that it is designed for local network access only. Although this is a feature that prevents it from getting hacked from outside sources, it limits the utility of the same MS Access database for multiple sites. Thus, MS Access is more suited for small and medium institutions, but has limited use in large hospitals. Finally, MS Access also lacks the robustness and scalability of other larger databases like MS SQL Server or Oracle. MS Access has no room for expanding the system once operations have become larger and there is a need for a bigger and more complex functionality. Pushing the disadvantages aside, Some notable examples of MS Access database currently in use include the academic model for the prevention and treatment of HIV/AIDS medical record system in Kenya, and the careware system deployed both in the United States and some countries in Africa. The AMRS was deployed from 2001 in a primary healthcare center in Masorayat, Nandi County, Kenya, and was previously known as the Masorayat Medical Record System. There are now more than 60,000 patients entered into the system, as well as more than 150,000 log visits in its 4 years of operation alone, and the numbers are growing. The database serves both the clinical needs of the healthcare center, as well as provide data for research purposes. The careware system in Uganda is built on a standalone MS Access database and geared towards supporting HIV/AIDS treatment. There are about 350 sites in the US and 2 sites in Africa that utilizes the careware system. It is a comprehensive tool that monitors and tracks HIV patient treatment. It includes clinical assessment, medication, and billing data. This is a proof of concept of the prototype design. This is a welcome page which can be designed for ease of use. Next, these forms are designed to be user-friendly, especially for those with minimal technical knowledge. Data is entered through these forms. Features and functions can be customized according to the needs of the institution. Buttons and easy-to-fill forms can be designed to be easily understandable. This slide shows a printable form that is similar to a paper-based document. This is a concept printable form for the West End Clinic located in Grand Bahama. This is to show that an MS Access database can be applied locally. Finally, simple queries and reports are designed for data collection for statistical purposes. There is a myriad more functions that can be inserted to meet the needs of the organization. This presentation is just to show that the concept is sound and feasible. In summary, electronic health record systems are the future of record keeping. It is a way of streamlining workflow and gives better access to patient health records. More than just keeping health record, the information gathered can direct proper utilization of resources and guide institutions to provide better service to their clientele. However, not everyone can afford an electronic health record system to achieve the above goals. Financial constraints, infrastructure challenges, technical knowledge of users, and logistical support are barriers that are constantly present in areas with low resources. These challenges prevent various communities from adopting electronic medical records to improve their healthcare delivery system. MS Access is an option that is worth looking into for those who need a simple, user-friendly database system for their own electronic medical records. It has a shallow learning curve and easy to maintain. There are security features that can also be added to the system to prevent data breach and ensure patient confidentiality. It is an option that most low-resource communities who want to move forward with digitizing their patient records. It can also be an alternative for healthcare authorities to monitor disease prevalence and aid in their policy making. Whatever the choice of database system the institution chooses, whether paper-based or digital, the end result should always be the welfare of the patients they cater to, as well as a tool to improve the healthcare delivery system in the community. These are my sources. And are there any questions? If any of the audience want a copy of the basic EMR database based on MS Access, you can email me and I will be happy to give it to you. Thank you.
Thank you, Dr. Kiano. I think I'm running a little low on time, so one quick question. I'm opening the floor.
Hi, can you hear me? So one quick question. That's an excellent talk. I'm always excited to see these things. My question is whether you had the opportunity to explore any open source healthcare records.
Oh,
So such as Open EMR, because there are
yes.
several of them which you could deploy to the cloud.
Yes. Yes, sir. I was able to look into OpenMRS, but between the learning curve of MS Access and OpenMRS takes a little bit more time to study, takes a little bit more time to design, and at the you'll have to have an IT team to look into it every time to keep it working, to keep it maintained.
Thank you, Dr. Dennis, for
Sorry,
the answer.
can I get
Dr.
a quick question? Dr. Hannah
Yes,
here.
ma'am.
Quick,
No,
quick.
Okay, my question is, how long has it, I might have missed it, how long has this been in use in Grand Bahama? And what are some of the challenges noted to present?
Actually, ma'am, it's not in use as yet.
Okay.
I did actually made a initial effort in one of the community clinics temporarily for about 3 months, and it was working fine. Actually, I didn't see any disadvantages at the time. Although I am constrained by the program that itself, because what we were using then was a mix of MS Access 2010 and MS Access 2019, which is a mix, but they both work. Unfortunately, for the MS Access 2010 version, a lot of the security features that is offered in the later versions are not present there, such as encryption, permissions, and all that stuff. So if it is going to be adopted, it is better to move from MS Office Suite from 2016 onwards. The more recent ones would have better security.
Was your study prior to Dorian, Hurricane Dorian?
No, ma'am. Actually, I was the community doctor in East Grand Bahama. So we lost all our records, and I wanted to. One of the reasons why I was pushing for this was that we are a country that is always prone to hurricanes, and the papers that we had there was one room. Uh, it was decades of all records, and we lost all of them. So I was pushing for an electronic medical record so that and I hope not, if there's another hurricane that comes our way, we don't have to take all the records. We don't have to take anything. All we have to do is just take the laptop, and that's it. We still have a record. Now, if there is another, because what we did there was a hybrid system, and it ran for about 3 months before I discontinued it. And what we had was a hybrid system where there is a printed version and an electronic version. The printed is just in case we don't have electricity, and the electronic is in case of we need to bug out of the clinic very fast. So we just take the laptop, and then that's it. We have a copy of our records.
Thank you, Dr. Kiano. I would have to stop here, and Dr. Dennis has provided his email, and I would want him to write in the chat so that anybody who wants any further information, they can access you. Thank you very much. Much appreciated.
Thank you, ma'am.
I would like to invite my next speaker, is a keynote speaker, Dr. Israel Posner, and he will be speaking on AI in healthcare delivery system. Dr. Posner is an anesthesiologist and pain management specialist. He's the founder of Pain Clinic Aruba NV and PCA 24/7. Dr. Israel is a distinguished anesthesiologist and pain management specialist with over 35 years of experience. He is a founder of those two clinics I told already. He is pioneering in online consultation in the region, specializing in minimally invasive procedures and advanced medical technologies. Dr. Posner has consistently improved the patient outcomes through the available two innovative pain managements. Uh, he has held various leadership positions, including medical director at Pain Clinic in Aruba, former Minister of Health of from Aruba, chairman of the staff board of MSAN. Dr. Posner also serves as on the board of Xavier Medical School Aruba, contributing to the academic and clinical training for future medical professionals. Dr. Posner has authored several publications in anesthesiology and management of and management and pain management, and has contributed to research in this field. In recognition of his contribution to healthcare, Dr. Posner was was awarded as an officer of the Order of Orange Nassau by King Williams Alexander at the Netherlands, fluent in Dutch, English speaking, and Papiamato. Dr. Posner continued. I'm so sorry, some of these spellings, right? Please pardon me for that. Okay. There's a lead advancement in the healthcare education. It's a lot. It's a lot. Dr. Posner, please pardon me for some of those things, but welcome here and thank you very much for your contribution, sir. You can start.
Thank you. Can you hear me?
Yes, we can hear you very clear.
Okay. By the way, it's Papiamento, and with that, I'm inviting you to come to Aruba to hear Papiamento.
Okay, thank you.
Okay, I don't have a beautiful PowerPoint presentation. When you're talking about artificial intelligence, as everybody knows, it's something really going really fast. Every day there's something new. So I hope you bear with me that I'm just talking and telling you some of the things that are happening. I guess I should say today and maybe yesterday and tomorrow, who knows. As you heard, my name is Dr. Israel Posner. I have had the privilege of working in anesthesia. I have no disclosure. Speaking at this prestigious event, part of the University of West Indies School of Clinical Medicine and Research Annual Research Day is an honor for me. I want to thank the organizers for this opportunity to discuss such an important, timely topic, the use and need of artificial intelligence in healthcare delivery. As we all know, this year's event themed the Innovations in Healthcare Empowering Lives, Advancing Medicine. AI is one of the most exciting healthcare innovations, potentially revolutionizing how we deliver care globally. From diagnostic to predictive analytics, AI has already shown its capacity to improve patient outcome, streamline process, and reduce cost. I have to mention that this year, AI played a pivotal role in 2 of the 3 Nobel Prizes. John Hopfield and Geoffrey Hinton won the Nobel Prize in Physics for their work on AI-driven deep learning, which models the brain-like neural network to perform tasks such as tumor detection. In chemistry, David Baker, Demis Hassabis, and John Jumper were awarded for using AI to design new proteins and predicting their structure with AlphaFold, a breakthrough that opens up vast possibilities in medicine. Both prizes highlight AI's transformative impact on scientific advances. However, while high-resource countries already benefit from these advantages, many low-resource countries are struggling with even basic healthcare infrastructure. This raises a fundamental question. Can AI help bridge the healthcare gap in low-resource countries? In today's talk, I aim to explore how AI can be that bridge, transforming healthcare in these settings. Let's begin by looking at the remarkable success AI has already achieved in healthcare. AI's ability to process large volumes of data rapidly and accurately has been indispensable in medical diagnostics. Over the past decade, AI has shown it can detect disease early and more accurately than traditional methods. AI systems like Google's DeepMind have been has made incredible progress in medical imaging. For instance, DeepMind's algorithm can diagnose diabetic retinopathy from retinal scans with accuracy comparable to that of top ophthalmologists. Early detection is crucial in preventing these conditions like blindness from diabetic retinopathy. AI also transforms pathology and radiology by analyzing biopsies and medical scans. A study published in Nature Medicine found that an AI algorithm could diagnose breast cancer from biopsy samples with greater accuracy than human pathologists. Not only does AI increase diagnostic accuracy, but it also speeds up the process, allowing healthcare providers to focus more on patient care. Predictive analytics is one of the AI's most transformative applications, as it allows the system to predict disease progression, potential complications, and treatment outcomes. AI is invaluable for managing chronic disease like diabetes and heart disease. It can analyze a patient's health data over time. Sorry. AI can also identify patients at high risk of readmission after discharge by analyzing their history, demographic, and treatment pattern. Real-world application of predictive analytics are already saving lives. For example, Duke University Sepsis Watch programs uses AI to predict sepsis in real time, significantly reducing sepsis-related death by enabling early intervention. AI-assisted robotic surgeries represent another area where AI is dramatically improving healthcare. Systems like the Da Vinci surgical system use AI to guide surgeons in performing minimal invasive surgeries more accurately. The AI helps to reduce errors and assist in complex procedures, including heart valve repairs and cancer resection. These systems improve over time by learning from thousands of procedures. In orthopedic, for example, AI-powered robotic assist with joint replacement surgeries, ensuring that implants are placed with millimeter precision. This combination of AI and human expertise leads to better outcome, shorter recovery times, and fewer complications. Let's look at another real-world example. The Beatrix Ziekenhuis Hospital in the Netherlands, where AI has been integrated into clinical decision-making. At Beatrix Ziekenhuis Hospital, AI is integral to clinical decision. Algorithms developed by PACMed assist in patient admission and ICU discharge. AI provides real-time insight based on patient data, helping the clinician make more informed decisions. Imaging an elderly man admitted to the emergency room based on his history, blood pressure, and other data, the AI predicts whether he should be admitted or discharged and estimate the length of his stay. AI doesn't replace doctors, it works alongside them. In this case, Dr. Nicole Decourt combined AI's recommendation with her clinical judgment before making the final decision. AI provides valuable insight and enhances human decision-making, leading to more effective care and better patient outcome. While AI is making waves in high-resource countries, can it have a similar impact in low-resource settings? Absolutely. Low-resource countries face many challenges, including overburdened healthcare systems, shortages of medical professionals, and limited access to specialized care. AI can provide scalable and cost-effective solutions to some of these challenges. Specialists are scarce in rural areas of low-resource countries, for example, parts of sub-Saharan Africa, and may have only one radiologist for an entire region. AI can step in to provide diagnostic support. In areas where limited access is to the specialist, AI-powered diagnostic tools can be a game changer. An AI system detects tuberculosis from chest X-ray. This AI analyzes the X-ray in seconds and provides a diagnostic as accurate as a trained radiologist, making it invaluable in areas where access to diagnostic services is limited. And it can do it in all the languages. AI is also transforming healthcare delivery through mobile health applications. The Babylon Health app uses AI to provide affordable healthcare via mobile phones. Patients can input symptoms, receive a preliminary diagnosis, and be referred to healthcare professionals if needed. This AI-driven platform has provided healthcare access to millions in remote regions. AI tools designed for low-resource countries are often created with cost-effectiveness in mind. AI-powered portable ultrasound machines are now used in rural Africa and Asian clinics. These affordable devices are easy to use and provide quick diagnosis, particularly in maternal health, where early detection of complications can be life-saving. To fully realize the AI potential in low-resource countries, we need strategies to make AI accessible and scalable. Partnerships with government, NGOs, healthcare institutions, and tech companies are essential to make AI accessible. One example is the collaboration between Microsoft and Kenya's Ministry of Health. They are working on AI tools for disease surveillance and maternal health, ensuring that AI solutions are adapted to the need of low-resource settings. Cloud-based AI platforms allow healthcare providers in low-resource countries to access sophisticated AI tools without expensive infrastructure. Zebra Medical Vision offers cloud-based AI services that allow clinics to upload medical images and receive real-time diagnostic reports, making AI accessible even in remote healthcare settings. AI is also a powerful educational tool for training healthcare workers in low-resource countries. AI-driven simulations allow healthcare workers to practice on virtual patients, honing critical skills even in under-resourced areas. AI-powered translation tools make medical literature accessible in local languages, helping healthcare workers stay informed on the last medical advances. About a year ago, ChatGPT did not speak our native language, Papiamento, and now not only it speaks it, it reads it, and it corrects it. So it's getting better all the time. And that's in a country that has only about 100,000 inhabitants. Despite its potential, there are challenges, of course, to implement AI in healthcare, especially in low-resource countries. The initial cost of implementing AI in low-resource countries can be prohibitive, but partnerships with governments and international organizations can help make AI more affordable. Limited internet access is often a barrier in low-resource countries. Developing offline AI tools or low-bandwidth platforms can help address these challenges. Building trust in AI is essential, particularly in regions where traditionally care methods are preferred. Education about AI's benefit and capabilities will be crucial for widespread adoption. I just wrote an article where I'm trying to predict the doctor of 2040, and you would be surprised the changes that we're going to see in the next couple of years. AI must be developed with the specific needs or low resource countries, ensuring that these technologies do not perpetuate existing biases or inequalities. Governments in low resource countries need to develop policies that ensure AI adoption while ensuring safety and efficacy. Countries must also establish data privacy laws to protect patients' information, aligned with international best practices. Conclusion: AI is not just a hype, but a necessity, and AI is not just a technological trend, it is an essential part of the future of healthcare. Its ability to improve diagnostics, streamline delivery, and empower healthcare workers is undeniable. Hospitals, in my opinion, must appoint chief artificial intelligence officers, CHIOs, to ensure AI proper integration. A CHIO would oversee AI adoption, ensure these technologies align with clinical needs, and comply with data privacy standards. By making AI accessible, affordable, and adaptable to unique challenges of low resource settings, we can ensure that healthcare innovation reaches every corner of the globe. AI offers better patient outcome, more efficient healthcare delivery, and empowered healthcare workers. For AI to reach its full potential, of course, governments, healthcare institutions, and technology companies must collaborate and drive this transformation forward. Thank you for your attention. I look forward for your questions.
Hello, thank you. Thank you, Dr. Posner. Yes, AI is here to stay. We all know that. And I appreciate your talk. It's okay if we don't have PowerPoint slides. That's perfectly fine. And I'm sure it has generated some questions in my audience. The floor is open, please.
Thank you for that talk, Dr. Postner. Dr. Hannah here. I was just wondering, this is the future. The AI is the future. And what positive effect does it have on, let's say, if you have staff shortage, human resources shortage? Is there a role for AI in that place? And in the future, will it be replacing some staff, human beings?
You know, that's a very good question. And I, of course, expected that question. First of all, I have to say, AI is not expected yet. I have to say yet, because the growth is a double exponential. It's straight up. Things that could not be done yesterday are being done today with all the developments, like companies like NVIDIA. They're developing special computers to be able to support AI. But at this moment, I would say a doctor without, let's put it this way, a doctor with AI might very well replace a doctor without AI. There was a report I read in Belgium. There was a hospital, and we can look it up if you want. They had to fire, or they fired radiologists because their error was 0.5%, something like that, whilst AI was 0, and AI could do thousands of readings at the same time that one radiologist does a couple of scans. And of course, it does it in all the languages. So not only did it do it faster, as accurate as a radiologist, but also in all the languages. So if you are in a clinic and you can use AI, I think that's a big advantage. The other day I was in St. Martin, and we finished with a patient around 2 a.m. And the neurologist, a very nice lady, she said, "Oh, after we did all this work, I still have to write a letter to the doctor I'm referring this patient to in Panama." So while she was telling me this, I scanned the papers that we make notes, and wrote the referral letter within a minute. And I showed her that. She goes, "Wow, what is? Oh, but it did it in English." I said, "Okay, wait, just a second." I pressed a button, and it changed it to Spanish. It's a very simple example, but very practical. And like this, we will see more and more things helping us every day. So I don't know if that answers your question, but I think AI, first of all, don't be afraid of AI. It's a little bit like having a tall ladder, going to the second floor in your home. You can keep it close so your children don't fall, or you can teach them how to go down the ladder. And I think we have to learn as doctors, we have to learn how to go down the ladder. So be open, have an open mind. Nowadays, you can get ChatGPT, there are many, and they're even free. So you can start asking it to write a letter, you can ask it questions, you can have it do your research for you. Of course, you always have to check it. By the way, this talk was mostly written by AI. I had to check it, and I told it what I wanted. It's called prompting, but it will help you in your daily routines. Does that answer your question?
Yes, it does. Yes, thank you very much.
Thank you, thank you, thank you. Yes, I guess. I mean, we just, whether we like it or not, whether we are afraid or not, AI is here to stay, and we better make use of it and try and give the mundane task, which we consider mundane, to the AI, and then do some valuable things, because we are still human and we are thinking for humans. So that is, I'm closing on that. Thank you very much, Dr. Posner.
Thank you very much.
Okay, so I'm going to the next one, and next one I have is my resident from anesthesiology, Yamir Smith. Am I correct? Yamir, you're here?
Yes, I'm here.
Yes, and she's a young lady, very busy. You can see that, and she's presenting on prevalence of multi-drug resistant and antimicrobial multi-drug resistance and antimicrobial resistance patterns in a tertiary intensive care unit. Retrospective analysis of 2 years in the Bahamas. Thank you, and you can proceed.
Okay, can everyone see my slide?
Please. Yes, we can see.
Okay, awesome. Thank you so much for that warm welcome, Dr. Frundo. My name is Dr. Yamir Smith-Carey, and I worked with my colleagues, Dr. Jessica Edwards, Dr. Mingo, Dr. Toot, and Dr. Monroe to piece together this study. I have nothing to disclose. Okay, so essentially our team generated an antibiogram, and an antibiogram is a summary of antimicrobial susceptibility data for bacterial isolates that were collected from a microbiology laboratory over a period of time. And antibiograms are very important because over time, they can provide information on changes in resistance patterns in these microorganisms, and this further influences treatment guidelines. Therefore, antibiograms are extremely important and an essential component for an effective antimicrobial stewardship program. Okay. So our methodology, we did a retrospective review of the ICU's patient log for the years 2021 to 2023. Patients in the ICU who were clinically suspected of acquiring an infection after 48 hours of admission were included in the data set. And we looked at the organisms that were isolated from urine cultures, respiratory samples, and blood cultures. And then we looked at the susceptibility patterns of these organisms. The final data set was analyzed using WHONet, which is a secured private software provided by the World Health Organization. Okay, so let's talk about the results. There were a final 492 patients included in the data set, and only 281 of them, about 57%, returned a positive culture, and we'll talk more about that later. In terms of the most common organisms, in our blood cultures, Staphylococcus aureus was the most prevalent organism, and about 43.7% of our Staph aureus isolates were methicillin resistant. In the urine, Klebsiella pneumonia was the most common organism, and Pseudomonas aeruginosa was the most common organism in our respiratory cultures. Unfortunately, about 63.8% of our Pseudomonas isolates were resistant to carbapenems, but only 26.8% of our Klebsiella pneumonia organisms were resistant to carbapenems. Okay. So this image was taken from the final antibiogram, and it just reaffirms that a good amount of our Staphylococcus aureus isolates were resistant to oxacillin and therefore were methicillin-resistant Staphylococcus aureus. So if you look here at this first circle, it shows that only 56.3% of Staphylococcus aureus isolates were susceptible to oxacillin. And at the bottom, we see that both Pseudomonas and Klebsiella were showing increased resistance to third-generation cephalosporins, which suggests that these organisms are starting to show extended spectrum beta-lactamase proteins, which is quite worrying. And if we look closer at Pseudomonas, it shows that only 46% of our isolates were susceptible to imipenem, which is a carbapenem, and that's very worrying. So this whole slide just shows that we are seeing an increase in multi-drug resistant organisms in our intensive care unit. So it's always good to look at how we compare to the rest of the region, but unfortunately, there weren't much studies published in our region. I found one in 2022 by St. Vincent and the Grenadines. Their national surveillance program collected samples from 2 of their major hospitals and all of their private and public laboratories, and they showed that about 23.6 of their Staph aureus strains were methicillin resistant, so that's less than us, and less than 5% of their Pseudomonas strains were carbapenem resistant. However, they would have had a larger sample size, so it would be unfair to compare, but there's always room for improvement. Our team did experience a few challenges when piecing this antibiogram together. One challenge was that we actually saw few or less than expected blood cultures from the intensive care unit, and this could have impacted the sensitivity of our results. There are many reasons why this could have happened, but I think this is a good point to reiterate that when we're working up septic patients, we're supposed to collect 2 sets of blood cultures from 2 different locations in the patient, and that we also should be using at least 2 mL of blood in each bottle in order to increase the chance that we'll catch the causative organism. And that's what this image from the Royal College of Pathologists is saying, that you need at least 10 mL of blood in order to get a good yield. Another unique challenge was that in our intensive care unit, we use paper data logs, and a lot of that data was lost. Some of it was destroyed, and that impacted our sample size. And there was also difficulty transcribing what was written in the patient log and putting that into the antibiogram, which also resulted in a low sample size as well. A unique challenge that we faced due to the COVID-19 pandemic was that our microbiology laboratory had some equipment failures. So for a few months, they weren't able to process our respiratory cultures. So that would have resulted in a loss of data as well. Nonetheless, moving forward, like I said, we do have areas to improve upon. And some of our goals with this antibiogram is that we want to actually continue publishing annual antibiograms, not only for the intensive care unit, but for the entire hospital. And we want enhanced antibiograms for special areas such as the neonatal intensive care unit and the dialysis unit. This will help us identify multi-drug resistant organisms earlier and also to monitor trends for their change in resistance patterns. We also want to improve practices of specimen collection in the ICU and in the hospital to optimize data accuracy and once again improve the management of infections and reduce the spread and burden of multi-drug resistant organisms. Most importantly, we want to provide regular training for the guidance on the use of the antibiogram regarding empiric antibiotic regimens. Thank you so much. These are my references.
Thank you, Yamir. It's a very good initiative, actually, and I think that should become the standard of care for all the time, not just for the study. And I'm assuming including Dr. Edwards into that. and she's working on that. Thank you very much. I'm opening the floor for just 2 quick questions so that I can have the second resident, please.
Can I ask a question?
Yes, go ahead.
Thank you, Dr. Smith, for this nice presentation. I have a quick question. By any chance, do you also test the personnel? Do you also sample the personnel?
No, we don't sample our ICU staff, but that is an interesting initiative. And I do think that we need to be tested, especially for methicillin-resistant Staph aureus. A few of us could be asymptomatic carriers, and that could lead to infection amongst patients as well as other staff members. So I do think that we need to look into that.
Thank you.
A quick question, please, Dr. Smith. Including the staff, the patient's family members that come into the ICU, would that be possibly a source? And how do you go about controlling that to prevent these infections? Because the rate that you're given is pretty high. It's high in most hospitals too, but we need to work to reduce that because it's not treatable.
Okay. So we do employ regular hand washing before families are allowed to visit the intensive care unit, but I'm not sure. Sorry, can you repeat the question? Hello?
Dr. Hannah, can you repeat the question?
Sorry, yes. What restrictions you have for family members? You have limitations on the number of persons. You also require them to do hand washing and sanitization, and also limitation as to what they do in the room with the patient. All of those things. What other barriers do you have in place?
Right. So like I said before, we do make hand washing required before they come into the intensive care unit and after they interact with their family members. And we do have a limit. I believe only 2 family members are allowed per patient, but those are the only limitations that I know so far. And Dr. Conliffe is saying that we actually do test staff for MRSA.
Yes, I'm thinking that it's coming from employee health. Yamir, thank you very much. This is the continuous field of research and improvement all the time. Thank you for your talk. I'm inviting the next person. I have a next resident again from the Department of Anesthesia, Avni Seymour. Avni, you're here. Is Seymour here?
Yes, sorry, I'm here. 1 second.
She's presenting on airway management for severe tracheal stenosis in a low risk setting. Dr. Avani Seymour, you can start. Thank you.
Hi, good afternoon, everybody. Can everyone hear me?
Yes, we can hear you and see your slides too.
Okay, good, perfect. So good afternoon again. This is actually a case report of a patient that we had a few months ago that I thought was very interesting and decided to share it because of how unique and rare it was. So this is the airway management of severe tracheal stenosis in a resource-limited setting. Of note, I have nothing to disclose for this. So I just want to introduce you guys to the case so that you can follow along and then look at it from an anesthetic perspective, give an overview of the difficult airway algorithms, give a bit of literature review in cases that were similar to this patient, but not exactly the same, and then just to summarize with some of the learning points from this case. So this was a case of TJ. He was a 37-year-old male, not known to have any pre-existing medical illnesses. All the information that we got from him was that he was a chronic marijuana smoker from his teens, so it was about more than 20 years that he smoked. He initially presented in January of this year to the emergency department with complaints of chest pain, increasing fatigue, and shortness of breath that had been going on for the past month. When he was worked up, his blood investigations were significant for leukocytosis of 55.9. He was anemic at 7, hemoglobin of 7.7. He had a platelet count of 746, and he was mildly hypokalemic at 3. With these symptoms that he presented with, of course, there was some imaging done to get a better picture of what was going on with the patient. And the chest x-ray showed that he had a large, well-defined homogeneous mass in the right upper lobe, with the medial border of the mass merging with the mediastinum and extending above the clavicle. There was also a verbal report that was given by the radiologist at the time, who described that his tracheal compression was that of 60%. And in the next slide is the chest x-ray when he initially presented to hospital that you can see. So as you can see in the right side of the chest, he has a very nice, well-defined mass that you can see is really compressing on the trachea, which was the starting point to how he would have presented from here on out. So eventually the mass was biopsied by the cardiothoracic surgeons who were now on board because of the location of this mass. And the pathology report showed that he had a poorly differentiated squamous cell carcinoma. And this report was 2 months after he had the biopsy done. I believe it was 5 days after his report came back was when he represented to the emergency room in severe respiratory distress. So he was dyspneic, he was tachypnic, he had a very audible stridor, diaphoretic, he was tachycardic, he could not lie flat, and of course he was complaining of chest tightness and discomfort. So the emergency physicians who dealt with him at this point may not have been the ones when he initially presented a few months earlier. And so not knowing the previous clinical picture here, one of their first thoughts were to rule out pulmonary embolism. And so he had a CTPA done. And the CTPA showed that he had a 13.7 by 11.7 paramediastinal mass in the apex of the right hemithorax, causing significant tracheostenosis. The report said that this had now worsened to about 80 to 90% from the previous 60% that was verbalized on his chest x-ray a few months earlier. And his mass was actually located at the level of T3 to T6. And so, of course, the source of his symptoms was found and PE was able to be ruled out. So this is the CT scan that he had done when he represented with these symptoms. So as you can see, the entire right side is basically filled with this tumor that he had at the apex of the lungs. And you can barely see any trachea because it's so compressed, this external compression from the pancreas tumor that he had, which is in keeping of why he presented in such respiratory distress. And so, of course, ICU was consulted because they wanted airway management. And at the time, I was the ICU on call, and I was also there with my consultant at the time, and we went to the emergency room to see this patient. But of course, we had lots of concerns for obvious reasons. Some of our concerns were, if we were to intubate this patient, would we even be able to advance an ET tube past this stenosis of this extent? If multiple attempts were required for this patient, we now run the risk of trauma and edema and bleeding into the airway, which could make a bad situation a pretty terrible situation. Would we be able to oxygenate or ventilate this patient, even if we were to intubate this patient? And would we be in a cannot intubate, but we are able to oxygenate this patient, or would we not be able to intubate this patient nor oxygenate this patient? And then in terms of an emergency airway, which is usually the last stop in the airway algorithms, essentially he wasn't a candidate for an emergency airway because of the level that the stenosis was at. And so we reached out to ENT just to make sure and just to get some feedback. And of course, they stated that this was out of their scope, obviously, because this tumor was extending from the thorax. So this was more in keeping with the cardiothoracic surgeons as opposed to the ENT surgeons. And so a rescue airway was not really an option for this patient. And then ultimately, what was the end goal here? We would intubate this patient, but that would only be a temporizing measure. So how would this all play out in the end? Well, luckily we were bought some time because this patient eventually settled on non-Maria face mask. And while he was in the emergency room, he actually did express to us that he did not want to be intubated unless he absolutely had to be intubated. So intubation must be the very last resort, meaning he had to crash and then he must intervene. But until then, he did not want anything done. His ABG at the time was a little more reassuring. It wasn't terrible, as you can see from the numbers. His pH was within normal range. PCO2 was quite fine. Oxygen saturations were 95%, and it was nothing alarming for us to need to intervene at this point. And so we admitted him to the hospital for closer monitoring, and we placed him on high-flow nasal cannula. About 2 weeks later, after our initial consult, we were then reconsulted because this patient had now come to that point that we were dreading, and he had a decline in GCS after he was initiated on chemotherapy by the oncology team. And his GCS fell to about a 6. He was an E1V1M4. And as you can see from his ABG result, he was suffering from hypercarbia with a PCO2 of 80. And so he became obtunded, which led to this fall in GCS. And so we had to take him to the operating theater for airway management. Surprisingly, when we got to the theater, his GCS had actually improved to about a 12, but the decision was still made to continue with this intubation because if a repeat of this scenario had happened, then we would be right back in the same situation, and it may be even worse the second go around. So we still decided to proceed with the intubation. Of course, we had the cardiothoracic surgeons there with us to give us as much help and assistance as we needed with securing an airway for this patient. So initially, we induced him with inhalational induction as opposed to a general anesthesia using IV induction because we wanted to try our best to maintain spontaneous breathing in this patient in the event that we ran into problems. However, we were struggling with opening his mouth. So we did give a small dose, a very small dose of sucks just to get the mouth open enough for us to take an initial look. So we dosed with about 40 milligrams, and we did a low dosing because we knew that if we had to dose again with sucks, one of the side effects of that is bradycardia, and we were trying to avoid that. So the consultant anesthetist at the time who was taking lead on this case along with the senior registrar for cardiothoracics, she went in with a video laryngoscope, and it showed that he had a Cormack-Lehane grade 3 view. And as you can see on the right side of the screen, a Cormack-Lehane grade 3 is associated with a difficult airway. And so we came out with a video laryngoscope after we saw what we were dealing with, and the cardiothoracic surgeon then proceeded with rigid bronchoscopy. Rigid bronchoscopy is actually the diagnostic gold standard for tracheal stenosis because it allows us to directly visualize the airway. And it's essential for determining if a patient is a candidate for endoscopic or surgical treatment. And it also allows us to simultaneously assess the vocal cord function and to get a better idea of the quantitative measurement of the stenosis. So for example, the length, the location, the extent of narrowing, the morphology, etc. And so we were able to advance this bronchoscope past the tumor, past the stenotic area. And a bougie was passed through the vocal cords, but unfortunately, when we tried to remove the bronchoscope, the bougie also was removed with the rigid bronchoscope. And so we had to make a very hasty decision as to what to do at this point. We decided to redose with a next small dose of Sux because, of course, by now that initial amount of Sux that we had given had already worn off. So we gave another dose of Sux, and intubation was attempted again with the video laryngoscope twice, but we were unsuccessful. At this point, the patient became bradycardic and he was hypotensive. So we ended up having to give atropine and small aliquots of epinephrine to try and get his vital signs back up. I do believe we also had to start him on a levo-fed infusion as well. We decided to attempt one final time, and with this final attempt, we applied very deep cricoid pressure, which allowed us to successfully place a size 8 ET tube, and we secured it at 28 centimeters at the lips. Normally, when we secure a tube in a normal patient, this is anywhere between like 21 and 23 centimeters at the lips, or less than 21. So as you can see, this is a big jump from what we would normally do, and it would give you an idea of how far down the stenosis was. And so we then moved the patient to the scope room where we used a flexible bronchoscope to visualize and confirm placement of the ET tube beyond the inferior border of the tumor. And so this patient was able to be intubated. He had a definitive airway, and we were able to then send him back to the ward with a clear airway. However, this, like I said, was just a temporizing measure. This was not definitive management for this type of case. And so there were a lot of critical decisions we had to make in evaluating an airway like this. Is this patient going to be a difficult airway? And he ticked that box, yes. Was the patient a challenge to intubate or reintubate? He ticked that box as well, as he required 3 attempts by the most experienced anesthetist in the room. Was the patient difficult to ventilate once intubated? Initially, no, he was not. And so I think this really played well on our part. We didn't have any issues with ventilation initially. Yes, he did have tracheal stenosis, and it was obviously very severe, according to the CT report, which is 80 to 90% stenosis, and the distance below the vocal cords. So like I said, the area of the lesion was at T3 to T6, which is basically in the chest, a good distance below the vocal cords, which was much further up around the area of about C4, C5, or 6. And so if you look at these guidelines, what makes this case so unique is because in any other case, we would follow these guidelines for a patient with a difficult intubation, but many steps along this guidelines, this patient wasn't really a candidate. As far as step B with placing a supraglottic, extraglottic device, this would have only allowed us to oxygenate initially. Ventilation may have still been an issue. And if you look to the right, it says that options would be to try and wake the patient up, which was really not the best option in this case, to try and intubate the trachea via the supraglottic device. But unfortunately, in our setting, we only have classic LMAs, so we don't have the LMAs to allow for intubation through that device. To proceed without intubating the trachea, we would have ran the risk of this happening all over again and ending probably worse. And the option for tracheostomy or emergency airway, which, like I said earlier, also was not quite an option for this patient. So we were in a very difficult and a very tough spot as to how to proceed with this patient. And so if we could go back to the beginning of this place, if we had what I would call a genie in a bottle that allows to have a few things that we could pick that would have really improved the outcome of this situation, what would we choose? So from an anesthetic perspective, as simple as the drugs that we use, I would opt to have something like rocuronium available because it gives you the same great ideal conditions as Sux does, very quick onset. However, it does not give you the adverse effects as Sux, such as bradycardia and the muscle pains and the other adverse effects of Sux. And it lasts a lot longer than Sux, so we would not need to redose. something as simple as Heliox, which is a mixture of helium and oxygen as well too. That is particularly helpful in patients in this situation with stenosis. Heliox would have gone a long way with a patient like this as well too. And then equipment such as a high quality video laryngoscope. The one that we used was a very good one, but it was actually the personal video laryngoscope of the anesthetist, the consultant anesthetist in the room, because the VIA that we had that belonged to the department was not a good quality at all. So it would not have provided us with an optimal view. And then, like I mentioned, if we had intubating LMAs, maybe this would have helped us to a certain extent. And then other equipment like an airway exchange catheters, maybe a gent ventilator to be able to ventilate through the rigid bronchoscope, and ECMO. From a surgical perspective, we would have definitely had a stent available for this patient because in patients in which surgery is almost impossible, after speaking with the cardiothoracic surgery, any surgical intervention for this tumor was unlikely because he was so advanced. And so his best and probably only option would have been the placement of a stent to provide palliative symptomatic relief in his case, or even a bronchoscopic balloon dilatation that would have also provided symptomatic relief, but that would also have been just a temporizing measure. But obviously we had none of these available at our institution. And so when I did a literature review, there were actually 2 cases in which patients prevented very similarly to this case, but still different because the cause of their stenosis was for different reasons. And also the area of their stenosis was much different from our patient. It wasn't as low as our patient. So these patients also prevented with very severe inspiratory dyspnea.
Sorry to interrupt your flow. Can you just speed up a little bit? All right.
Sure, no problem. For these patients, basically ECMO was a life-saving procedure for these patients, and it allowed them to have their definitive surgeries done, and they were successfully extubated and discharged from hospital. And so in summary, essentially what we learned from this case is this element of tracheal stenosis is very rare and unique, and it presented a very significant challenge for both us and the surgeons. And it becomes even more difficult when we don't have access to certain equipment and resources to deal with these type of cases. We wanted to commend the A&E team for knowing when to refer to us and not to go ahead and prematurely intubate this patient, which could have ended disastrously. And the importance of knowing multidisciplinary management with ourselves and the cardiothoracic team, and also the importance of airway algorithms when it comes to patients with difficult airways. And so I just want to acknowledge the airway response team that was involved with the case, the cardiothoracic surgical team, and also the UWI SCMR staff and research team that allowed me to present this case. And thank you. And these are my references.
Thank you very much, Dr. Seymour. It's an interesting case. Sometimes what you can say, you do learn. You learn much from these unique cases. Dr. Hanna was asking one quick question: what was the cause of delay in intubation? But I think you already said that the patient did say that he wasn't really.
Yes. Correct. The patient had said from the jump that he did not want to be intubated. So of course we could not proceed until he absolutely needed it, which is when he was obtunded from the chemotherapy, we believe, and he was hypercapnic. So that's when we intervened.
Sorry, that delay was what was the cause of delay with the pathology report initially?
Understandable.
And yes, you answered the other question about his wishes, but did he have a psych evaluation based on his wishes?
No, actually, he did not have a psych evaluation. After we had a thorough conversation with him about how the situation could potentially end, I think he just wanted to not get to that point until he absolutely had to, and which is why he held off, which is what I believe. But no, we did not get a psych eval. We believed him to be in his, essentially in his right mind and everything, and those were just his wishes to not have anything done until then. In terms of the delay, I believe it is a flaw of our system because the biopsy was done from March, but like you said, like the result didn't come out until May, which is a huge discrepancy and a gap. And so it also delays treatment because obviously oncology was not able to get involved until we confirmed what the biopsy showed as well too. So it is a flaw of the system, and this is something that we face very commonly, unfortunately, at the institution where we have very drawn out time periods until we get results.
Yes. That's the personnel problem in pathology. If you don't have enough people, you don't really get the report.
Correct.
Thank you very much.
Yeah, I just have can I ask a question? I just wonder why radiotherapy was not considered, like if he was given 25 centigrade and the next fraction later in the day 50 and then 75 the next day and so on. He probably would have responded immediately. I mean, the argument is, does he have compression or does he have stenosis? Obviously, if he has stenosis, radiotherapy probably wouldn't improve it. But if he has just external compression, radiotherapy would get him into a better space. And then you could consider definitive radiotherapy, especially for a squamous pancoast, as curative versus a chemotherapy, radiation, or just chemo-based approach. So did you consider radiotherapy from the beginning? Because I think as you pointed out, a multidisciplinary context and decision-making is very important to include all the people on the team. And I managed about 10 or dozen of these patients with success in the past using radiotherapy. So that's why I asked.
Thank you for your input, Dr. Israel. Okay, so I think I have to stop here for a short sponsors video. Dr. Holiday, am I correct? Sure, I think a short video is there. Is it? Dr. Holiday.
Welcome to another Nestle Education segment bite for healthcare professionals only.
And then we can reconvene.
The World Health Organization recommends exclusive breastfeeding during the first 6 months of life and continued breastfeeding for as long as possible. In our quest to provide the best, we have gone a step further, studying breast milk to understand what it delivers for growth and development. This study has birthed our newest option, NAN, with optimized protein, probiotics, and human milk oligosaccharides, while maintaining the proven macro and micronutrients we combined before. As we balance the ingredients of our exclusive combination for reconstitution by your little patients, we ensure even more of the solid components are represented in our infant formula, now including HMOs, specifically 2FL found in 80% of breast milk worldwide and account for 30% of the HMO component. Coupled with the right amount of protein for structural cell and tissue formation, essential neurons and hormones, and general overall body functions, NAN has all that an infant formula currently needs. Even the probiotic blend is superior among infant formulas on the market with our specific selection for the growing infant. Choose NAN with your patients unable to breastfeed for this exclusive combination today. For any further questions, please reach out to a Nestle representative via telephone or WhatsApp. Do enjoy a fruitful conference. Goodbye.
With breast cancer across 4 generations, a cross-sectional study. Ms. Dr. Schlimbrecht hails from the University of Miami Miller School of Medicine, Vice Chair of Global and Community Health, Director, Gynecologic Oncology Fellowship Program, co-lead, and Gynecologic Oncology Site Disease Group, Medical Co-Director for Research Operations, SCC Survivorship Program. Dr. Schlumbrecht is a professor in the Division of Gynecologic Oncology at the Sylvester Gynecologic Oncology Fellowship Program, Medical Co-Director for Research Operations, Cancer Survivorship Program, and the Co-Director of Cancer Control and Prevention for Gynecologic Oncology. He also serves as the Vice Chair of Global and Community Health in the Department of Obstetrics, Gynecology, and Reproductive Sciences. A graduate of the University of Texas Medical School at Houston, Dr. Schlumbrecht completed an OB/GYN residency at the University of Texas Southwestern Medical Center in Dallas and a Gynecologic Oncology Fellowship at the University of Texas MD Anderson Cancer Center in Houston. He holds a Master of Public Health in Epidemiology from the University of Texas. His clinical care of patients is complemented by his ongoing research in education, global health, and healthcare disparities, with a specific interest in cancer prevention, early detection, and education in underserved populations. He is the international mentor for his gynecologic oncology fellows in Nigeria and Bahamas, and works closely with global partners to facilitate comprehensive research in endometrial and hereditary cancers. He is a recipient of the 2021 Sylvester Comprehensive Cancer Center Zubad Award for Outstanding Teacher. He has published in numerous peer-reviewed journals, including the Journal of Clinical Oncology, Clinical Cancer Research, Cancer and Gynecologic Oncology. Please welcome Professor Matthew Schlumbrecht with Reproductive Risk Factor Patterns in Caribbean Women with Breast Cancer Across 4 Generations, a cross-sectional study. Professor?
Good evening. Thank you so much for that very nice introduction. I really appreciate it. It's a pleasure to be here, and I'm so grateful for the invitation to speak with you all today. Let me go ahead and share my screen, and we'll go ahead and get started. Okay. So as mentioned, we'll be discussing reproductive risk factor patterns in Caribbean women with breast cancer, and we'll be filling in some of the gaps. I have no disclosures except that I'm a gynecologic oncologist, so I actually don't treat patients with breast cancer, but I've been working with the team who will be discussing later on in this presentation on patients with hereditary cancer syndromes, and today our focus will be on breast cancer. So our objectives for this talk are to describe the general epidemiology of breast and gynecologic cancers in the Caribbean, to discuss the prevalence of the hereditary breast and ovarian cancer syndrome in the Caribbean, and to discuss temporal trends in reproductive factors and age at breast cancer diagnosis in Caribbean-born women. So we know that the burden of cancer is very high in the global south. And if I can first direct you to the legend at the bottom right-hand side of the screen, you'll see that the red dots represent Africa and that the yellow dots represent Latin America and the Caribbean. When we look at gynecologic malignancies inclusive of ovarian, uterine, and cervical cancers, we can see that to the right and up, we're seeing not just increased incidence, but increased mortality. When we look specifically at ovarian cancer, we see overrepresentation in Trinidad and Tobago, Bahamas, French Guiana, and Barbados. And in uterine cancer, overrepresentation in the Bahamas, Jamaica, Trinidad and Tobago, Barbados, and Cuba. And you can see specifically for uterine cancer, marked increase in not just incidence, but mortality in the Caribbean all the way to the top right. When we look at breast cancer, we see that there is also a significant burden of breast cancer in the global south. When we're looking specifically at regions in the Caribbean, we can see in terms of breast cancer incidence and increasing mortality that we are seeing overrepresentation in Jamaica, Bahamas, Barbados, the Dominican Republic, and Trinidad and Tobago. So from an epidemiologic perspective, as we go through time, both breast and gynecologic cancers are increasing in incidence, but we're also seeing increasing deaths. So when we're thinking from a very high level about cancer incidence and the risk factors for cancer, we can really think of it in terms of genetics and in terms of environmental exposures or other. So what I want to talk about in the first part of this talk is generally a review of cancer syndromes, and I think that'll dovetail into why we sought to pursue information about the reproductive factors in women with breast cancer. So very generally speaking, cancer syndromes produce higher than normal levels of breast, ovarian, and endometrial cancers, in addition to things like colon cancer, pancreatic cancer, stomach cancer, and patients whose families are genetically at risk. Hereditary factors can either be proven or suspected, meaning that they can be proven through genetic testing that's conducted with an objective outcome, or suspected based on a pattern of occurrences and what we see in specific families' histories. And this is represented here in the pedigree at the bottom center part of the page. Now, when we look at hereditary breast and ovarian cancer, we know that there is going to be a significant increased risk relative to the general population. And it's important to delineate between a cancer that's hereditary versus one that is sporadic, because sporadic cancers mean that the patient does not have an inherited or familial genetic predisposition to developing cancer. If we compare breast cancer to ovarian cancer, we can see that up to about 14% of breast cancers are hereditary. And in terms of ovarian cancer, we can see that up to about 25% of ovarian cancers are hereditary. That's in the general population. When we consider the Ashkenazi Jewish population, which for decades had been kind of the landmark population of an increased risk for genetically driven cancer syndromes, 40% of ovarian cancers are actually in women who are of Ashkenazi Jewish ancestry. So some of the challenges with hereditary and familial cancers is that first, most men and women who carry a cancer genetic mutation and those who are going to be at risk don't know. And some of that is due to the fact that these tests are relatively new. When we look at BRCA testing, we're looking at something that's less than 25 years old. But another challenge is that these tests can be cost prohibitive. And so even if somebody has a family history which is suggestive of a hereditary cancer syndrome, they may not be getting tested. Similarly, patients may sometimes not know their family history because other family members may be hesitant to disclose that they've had a cancer diagnosis. In a hereditary or familial cancer, we know that the lifetime cancer risk is going to be markedly elevated. So for example, if we look at ovarian cancer, the general population has about a 1 in 70 risk, so it's about 1.5%, versus, for example, BRCA1, in which that risk is 46%. So you can see there's a substantial discrepancy there. These cancers are characterized by diagnoses often at younger ages. The elevated cancer risks are seen in both men and women. So when we're looking at something like the hereditary breast ovarian cancer syndrome, those genes are not specifically to breast and ovarian cancer at all. In BRCA2, for example, men are at increased risk for breast cancer. We know that there's an increased risk for pancreatic cancer, for example. And so it's very important to recognize that these are not cancer syndromes that are solely affecting women. The importance of these, though, is knowing a genetic mutation is present is very empowering because we can take measures to prevent cancer. So in a sporadic cancer, essentially what happens over time is that there is this accumulation of mutations in the tissue of interest. But because it takes so long, we are generally seeing cancer incidents occurring when people get older. When somebody has a hereditary cancer, they are already starting with a germline pathogenic variant. And so there's an abnormality in often some sort of DNA repair mechanism that over the course of life and additional insults really induces further somatic mutations in oncogenes and tumor suppressor genes. And so the diagnosis of a hereditary cancer, because of these kind of two hits, really occurs at much younger ages. So Judith Hurley, who's a breast medical oncologist at the University of Miami, really kind of started to see patterns in women from the Bahamas as early as the first decade of the 2000s. And in speaking with her, she tells about how women were coming in from the Bahamas with breast cancer, many of which had triple negative breast cancer, and many of whom were being diagnosed at very young ages, including their 20s and their 30s. And so when we looked at the data, and this is a breast cancer data, breast cancer age of diagnosis comparison between women from the Bahamas and then with those born in the United States, Bahamian women are in green. You can see that there is significantly increased numbers of women being diagnosed in their 20s, 30s, and 40s. And that's relative to what we see more commonly in the United States, where beyond age 60, we kind of start to see an increase, although we do see it as young as in their 40s. but very uncharacteristic to see breast cancer in someone in their third or fourth decade of life. And so it's really important to then understand what would the potential genetic risk be for the breast and ovarian cancer syndrome. We know in the United States that 3 to 5% of breast cancers and about 20% to 25% of ovarian cancers are due to mutations in the BRCA1 or 2 genes. We know that the overall mutational frequency in the United States is about 1 in 400. And again, about 1 in 40 Ashkenazi Jewish women are going to have some sort of hereditary breast and ovarian cancer syndrome gene, most notably BRCA1 and 2. And so when we start to see these epidemiologic patterns of women from a specific region being diagnosed at much younger ages, that really kind of calls into question if what we're seeing is actually an underlying cancer syndrome. And so this is a paper from many years ago. Senior author is Dr. Nayrod. You can see Dr. Hurley's name right in the middle, as well as some other folks who are on this call, including Dr. Halliday, really kind of evaluating the prevalence of founder mutations in BRCA1 and BRCA2 in women who did not have cancer in the Bahamas. I think probably the thing that is most notable here is that in patients who had a relative of a known carrier of a BRCA mutation, 38% of those had a mutation identified. And so this is very important because when we look at cancer prevention efforts, one of the things that we employ most frequently is called cascade testing. Cascade testing involves identifying the proband or the person who is carrying the mutation, and then identifying family members who would have similar mutations who may also be unaffected from a cancer diagnosis perspective. And so this really showed that there was a significant opportunity to improve genetic testing because there were going to be a substantial number of women at risk. So this is not unique to the Bahamas, actually. What we're seeing on the left-hand side here is data from Haiti with a colleague of ours, Vince DiGennaro. And these are all in women with breast cancer. You can see that there is a substantial, more than 20% group of women who are diagnosed at age younger than 40. And you're seeing significant numbers of women who present with advanced stage disease. One other thing to kind of note below is the hormone receptor status. So only about half had ER positive disease. 1 in 5 had HER2 positive disease, but almost 40% had triple negative disease. When we look at Barbados, we can see that relative to age, those with triple negative breast cancer were diagnosed at younger ages than those who had non-triple negative breast cancer. And when we look over on the right-hand side, triple negative breast cancer is an advanced high-grade disease. And so we can see that the vast majority of those were grade 3 with substantial abnormality, which also translates into early metastatic disease, as well as more challenges with treatment. And so Dr. Sophia George, who is known to many of the people on this call, initiated a prospective multinational study of 7 Caribbean countries, which you can see listed here in the figure. And the goal of this was to essentially identify what the prevalence was for BRCA mutations in women who had diagnoses of breast and ovarian cancer patients. We wanted to determine specifically also the types of breast and ovarian cancer in the Caribbean, and then to determine if there is a potential founder effect in the Caribbean. To participate in this study, patients needed to have a confirmed diagnosis of invasive breast or ovarian cancer. At least one grandparent needed to be born in the study site, and that was really to kind of define nativity and show that there had been some longevity of that family in that specific geographic location. All of these patients signed informed consent, and then a multi-gene panel test was confirmed on the germline. These are all saliva samples. You can see here in the figure, again, the specific islands which were represented as part of this study. And so this was actually a very robust cohort with more than 1,000 participants, and these people were accrued very, very quickly. The vast majority, as you can see in the second line, were breast cancer, about 98%, and only 2% were ovarian cancer patients. The age of diagnosis was young. We're talking about patients in their mid-40s. Although you can see when you do countrywide comparisons that there were differences and variations in the average age of diagnosis. So again, for example, breast cancer in the Bahamas with an average diagnosis age of 44.9, but in contrast in Cayman Islands, it was 52.5. When we kind of go down to the germline variants, which you see in the red box below, we can see that just over 14% of patients were determined to have a germline variant. 9% had BRCA1, 3.2% had BRCA2, and 1.3% had PALB2. When we look at characteristic differences between the variant carriers and non-carriers, these data are not really a surprise. So the age of diagnosis for patients with breast cancer was 7 years younger than those who did not have a BRCA or pathologic germline mutation. We did see some similarities in the ovarian cancer cohort, but again, we were talking only 2% of the cohort, so it's hard to draw meaningful conclusions from that. Interestingly, when we go down to the triple negative breast cancer, we can also see that those who had pathogenic mutations had more than double the risk of a triple negative breast cancer. That was statistically significant. And then again, when we looked at specific relatives who had breast or ovarian cancer, and that's kind of in the middle of the page here, we can also see that, again, having a family member with a cancer diagnosis that falls within the hereditary breast ovarian cancer syndrome really does increase the risk. One of the things that's important to note, though, is that this risk is not the same throughout all of the islands. So in the Bahamas, we saw the highest prevalence of the hereditary breast ovarian cancer syndrome, but that was not the case throughout. In Barbados, it was 17.4%. In Trinidad and Tobago, it was 11.7%, but then it went down to as low as 5.5%. So this also speaks to kind of the geographic isolation that occurs in the setting of the islands, wherein if there's a pathogenic mutation, there's kind of a genetic augmentation just given the population constraints and the geographic constraints. But important to note that we're not seeing some sort of homogeneity throughout. This is a little blip that was added about the Dominican Republic. We recently completed a prospective study. This is representative of 155 patients we enrolled in Santo Domingo at a hospital there with similar inclusion criteria. And again, you can see that there's variation. Another important piece is that the proportion of pathogenic variants differs by country. So in the Bahamas, we see substantial overrepresentation of BRCA1 mutations, but that is not the case throughout. In Dominica, there were no BRCA1 mutations, only BRCA2 and PALB2. Jamaica had a much higher proportion of patients who had PALB2 mutations. The next highest group with BRCA1 was Trinidad and Tobago. We did capture other mutations in the Fanconi anemia pathway, which include ATM, CHEK2, NBN, RAD51C, as well as others that are not necessarily associated with high-grade serous carcinoma. Those are STK11 and TP53, which we can also see with some other hereditary cancer syndromes. So it's important to acknowledge that hereditary predisposition for cancer is substantial. However, the vast majority of patients, as we mentioned earlier, are not going to be those who've got a hereditary predisposition. So what are some of the other factors that are including breast cancer risk? We know that being female, being older in age, having a diagnosis of DCIS or LCIS is going to increase the risk from a major perspective. That's in addition to having a BRCA1, BRCA2, or other gene in the Fanconi anemia pathway. But other reproductive associated factors are going to be very important. That's things like age at first pregnancy, the number of pregnancies, the number of full-term pregnancies, the age that a woman undergoes menarche or the initiation of her period, the age of menopause, which is the cessation of period, and then again, recognizing that protective factors, including breastfeeding, first childbirth before age 30, and exercise can also be protective. So how do we kind of look at this, and what is the relevance of this in this population of study? And so utilizing this same cohort, we did a secondary data analysis to evaluate reproductive risk factors and the patterns of them in Caribbean women across 4 generations. And so we were essentially comparing temporal changes. And so the ultimate question here was, is there a temporal trend in reproductive patterns and age at breast cancer diagnosis in Caribbean-born women who are part of this cohort? This paper was just published actually several weeks ago, so we're excited to share these data with you. What you'll note at the top of the figure over here is that these 4 columns represent women who were born in various years. On the left-hand side, it's less than 1950 or before 1950. The second column is 1950 to 1959. The third column is 1960 to 1969. And then the fourth column is those born 1970 or greater. What you can see is that the age of breast cancer diagnosis over time went down significantly, such that those born before 1950, the average age of breast cancer diagnosis was 60 years. And for those born after 1970, it was 35 years. So we're seeing a shift of about 25 years. When we are looking at BMI and trends of BMI over time, you can see that the proportion of women who were obese trended to kind of go down. But we still see significant overrepresentation of women who were 65 to 70% of those of the population being characterized as such. When we go down to number of siblings, what we can see is that the number of siblings starts to go down. This is likely due to changes in reproductive habits within the community. And then another important piece is this age at menarche. So we can see that women are starting to get their periods at younger ages over the course of generations, and really recognizing that early menarche and that early exposure to estrogen may have a significant impact on breast cancer risk. If we go up over here, we're looking at gravidity. What we can see is that women were having fewer babies as time went on. We could also see that the number of full-term pregnancies went down. Those were both statistically significant data points. One thing that I think is probably not a surprise is that the proportion of women who were undergoing hysterectomy with bilateral salpingo oophorectomy decreased over time. This is likely due to changes in the ACOG recommendations about workup for hysterectomy and really kind of maximization of medical efforts to avoid hysterectomy. When we look at temporal trends in the surgical treatment for the uterus, really even into the 1970s and 1980s, at the completion of childbearing, there was kind of this expectation that women would just have their hysterectomy. But as we've started to kind of increase the armamentarium of medical treatments, that has fallen less out of, or more out of favor, and so fewer women are having these surgeries. When we look at postmenopausal status, we can see that the age of menopause was changing, and that's further represented down here, so that the mean age at natural menopause was 49 years in those born before 1950 and went down to 41. There was no statistically significant difference in the germline or likely pathogenic variant across the spectrum here, and similarly, no difference in the ER positive disease. What we did here then was then break down the reproductive factors in the presence of either a positive or negative test for a pathogenic germline variant. And so as we go through this, you'll see some things that are not very surprising. The age of breast cancer diagnosis was about 7 years younger in those who had a BRCA1 or 2 mutation in this population. BMI was not significant. Family history of breast or ovarian cancer, not surprisingly, was significant in these patients. What was interesting, though, is that the number of siblings, the age at menarche, the gravidity and parity, and age at first birth had nothing to do, or there was no variation between those who had a pathogenic mutation and those who did not. Interestingly, when we look at those who had a THBSO, we did see actually a higher likelihood of those who had a pathogenic mutation to have a HIS-BSO. That's actually a good thing. We were probably reducing the risk of some people's ovarian cancers inadvertently. But then again, not surprisingly, when we look at estrogen receptor, we did see a difference, recognizing that the BRCA1 mutants are most likely going to have triple negative breast cancer. And that's reflected here, where we can see a lower percentage of patients who had a germline variant with positive estrogen receptor on their IHC. So what are the take-home messages here? So we know that hereditary cancer syndromes play a significant role in breast cancer risk in the Caribbean, and as we saw here, especially women of the Bahamas. But there are also changes in the reproductive factors of women in breast cancer over time. So we're seeing increasing percentages of people who are overweight and obese, a decreasing age at menarche, fewer pregnancies, which translates into potential younger age at diagnosis. And so really kind of these estrogen exposures and what we're seeing in terms of interruption of these estrogen exposures is really important. And at least for the sporadic breast cancers are likely playing a role. But it's important to also recognize that even though we've got germline mutations, which increase the risk for cancer, it's not absolute, right? So if somebody has a pathogenic mutation, there's not a 100% chance that they're getting breast cancer. Similarly, if somebody is overweight or if somebody goes into or starts menarche early or has no pregnancies, all of these other kinds of reproductive factors, that doesn't necessarily 100% translate into breast cancer. So there is this kind of interaction between biology and environment. And so as we look at this, we can't modify our genes, but there are other things that we can modify. We know that being overweight and obese increases the risk for breast cancer. So what do we do to modify that risk factor? We know that diets that are high in fiber, high in fruits and vegetables, and I know everybody hates this, but trends to be, it's more important to have more veggies than fruits. When you've got fatty meats or processed foods, these are all things that are potentially modifiable. And we do know that when we're looking at, for example, meats that are high in fat or processed foods, that there is an inflammatory response within the gut, and this increased inflammation really does translate into increased risk for cancer incidence. Exercise will reduce the risk of cancer. We know that it also has positive cardiovascular events. And then obesity, weight loss. So if we've got patients who, in addition to dietary changes, these are people for whom either medical treatment for obesity, we have all of the GLP-1 blockers now, which are really very positive in terms of influencing the obesity epidemic. And considering in some cases bariatric surgery. We know that alcohol use increases the risk for cancers kind of across the board. We can see that in breast cancer, not by a substantial amount, but making sure that modest alcohol use is considered. So this is some of the team, not all of the team. And again, many of these people are on this call. I do want to thank Dr. Sophia George, who led the Caribbean Women's Health Study, Judith Hurley, who really kind of from the Miami side was one of the first people to identify this. Alex Covarrubias Sanchez is our PhD candidate who did all the data analyses. He was the primary author on the study. And then Priscilla Barreto Colo, who was the co-author for this. So with that, this is my family from Sylvester. I want to thank you for your time and attention. I'm happy to answer any questions that you may have.
Thank you very much, Professor Schlimberg. Recht, are there any questions for Professor?
Yes, Dr. Hannah here, sorry. My question relates to why there is an increase in death in the females, and is there also a similar trend with the males that may have breast cancer? That's one question. And then my next question was related to why there are more mutations in the Bahamas, and what are some, is abortion or miscarriage one of the factors that might contribute to it? Those are my questions.
Okay, thank you. So the data that we presented in those first couple slides, those are GlobalCan data. And so they actually don't tease out the differences between male breast cancer and female breast cancer. So I actually don't know the answer if we're starting to see the increased risk for the males with breast cancer. Male breast cancer is more often driven by a BRCA2 mutation. Those very commonly are estrogen receptor positive. And I think what we're seeing in terms of the increasing death for breast cancer is really the shift toward increasing rates of triple negative breast cancer. We do know in terms of the genetic mutations in the Bahamas that there is a founder mutation here. When we are thinking about how genetic abnormalities can get augmented in a population, I really think the geographic kind of distribution of the Bahamas drives a lot of this, because we're looking at an archipelago with multiple islands. And so when we're looking purely from like a population admixture perspective, there are fewer persons than if you were, say, in Brazil. And so there's this kind of augmentation and genetic drift of these mutations with kind of accelerated penetrance here. The reproductive factor that you're talking about, so actually a miscarriage or abortion doesn't have anything to do with a germline or genetic mutation. The importance of recognizing the difference between a pregnancy that was carried to term and one that was not is really kind of understanding the length of time that somebody had a change in their cycle. So when somebody's got a pregnancy, again, we're talking about 40 weeks, there is, suppression of ovulation, and we know that there's kind of a large bolus of progesterone that is delivered by the placenta. When somebody has a miscarriage, that's typically going to be in the first trimester. And so there isn't as much of an interruption in ovulation. And that substantial change, when we're looking at multiple pregnancies, really kind of translates into a difference in systemic estrogen exposure, which is what is hypothesized to be contributing to the breast cancer risk.
Thank you very much. Does that answer your question? Any other questions? Okay, thank you very much, Professor.
Thank you so much.
You're welcome. Okay, next, the last, we wrap up this session with Dr. Glenn Jones presenting the role of composition in medical education. Dr. Jones is an assistant dean at the 3 Caribbean medical schools of SABR, MUA, and SMU, 2020 to present. For 4 decades, he was the radiation oncologist in Canada and in Antigua and Barbuda before becoming a full-time academic and medical educator. As a methodologist and biostatistician, his research interests continue in preventative nanodentistry with Greenmark Biomedical Incorporated, in machine learning applications in diagnostic radiology, and in natural language programming applications in medical education. Please welcome Dr. Glenn Jones in the role of composition in medical education.
Dr. Jones, you need to unmute.
Dr. Jones, are you here?
Sorry, you may not be able to hear me. Can you hear me now?
Yes, we can hear you now.
Okay, and can you see the whole slide?
Yes.
Okay, good. Okay, so I really appreciate the opportunity to present. It's an honor, and the quality of the most recent presentations have been quite high, so I really appreciate the opportunity to attend this conference and participate. I hope that what I present is also of high quality. Obviously, medical education is typically of less importance to clinicians, even though it's very important to a national strategy towards advancement. And so I'm coming at this from a little bit of a slanted perspective, having been a clinician for 40 years, roughly, and now for 4 years as a full-time academic in medical education. But medical education is very important. And what I would like to talk about is a concept of shifting the way we think about some of the assignments in that we have students do, thinking about them in a larger context of what I call composition and what other people have called composition, but it's not been really reliably picked up in the literature. So I would like to focus on that as a way to integrate some of the information. So I represent, obviously, myself with a BSc, MD, FRC, BC in radiation oncology and Master of Science in Statistics and Epidemiology, but also as an assistant dean at 3 Caribbean of the 40 plus IMG type medical schools, present information about, is composition relevant to medical education? And if so, can we optimize it? So I represent 3 schools as listed below, which in composite include approximately 500 medical students currently. And so my interest is, do we generate good graduates? And with each student approaching 6 or 30,000 potential future patients and their families even larger, do we really help them? And so is composition as a concept useful in our approach to medical education, and could it make these students better? So I have some declarations, like nothing is related to the topic other than my employment at the 3 schools, advancing AI and machine learning, which I'm currently focused heavily in terms of preventative dentistry, diagnostic radiology, and at R3I for automated scoring of submissions of assignments, for example. I do include a lot of details on these slides. There's only about 20 slides to look at. So you can ignore the sub-points if you just want to listen to me. You don't have to read everything that's on the slide, because I'm basically going to recapitulate what's on the slides, given the time constraint to prepare this. And I will provide the presentation and references if you contact me at the email address. So just give me a couple of weeks to kind of consolidate that, and then I'll definitely get it to you. So the outline is that we want to summarize, and 3 objectives that were put forward were to summarize published literature on compositions with a focus or attention on constituent relationships. And that means, can we learn medicine and clinical care through what I call, or what other people have called, compositions? And do they help develop language, thinking, and reflection? It sounds rather abstract, but you'll see how important it is to medical education and your own clinical practice when I actually review it. Can we share scripts to embody what I call, or what other people have called, clinical ontology? So we develop personal scripts or approaches to thinking about patients, but then we share these. And in the process of sharing them, they become what's called ontologies. So I will discuss that. And that's important for machine learning and AI. And then what about using compositions for assessment? So if somebody writes something or presents something, is that useful for assessments of the development of this medical student? And even if you extend it, is it useful for board tests every 5 or 10 years on actual attendees? And then, just to keep you going right to the end of today, because I know you've already had a talk on augmented and artificial intelligence, but you may be dwindling at this point because it's a long day and you may not want to listen to me talking about medical education. I want to invoke and demonstrate that augmented and artificial intelligence may be of value. So then we can have a summary and discussion. So we want to summarize the literature with attention to constitutional or constituent relationships. So that's the first objective of this talk. So the challenge in making a physician is, obviously, it's a complex task. We need to have a student acquire significant knowledge and skills, but we also need them to pass regulatory milestones like exams attained at their level of training. So the trainee must have curiosity, creativity, but must also conform to what we expect in the caring space. They can't just be creative and curious, but do whatever they want. We don't allow that for regulatory reasons. Now, we capture this well in the competencies, the CanMeds, and the EPAs, as listed here, but we need to think about 2 aspects. One is that we really have a well-developed set of medical schools. They have residency programs attached to them typically, and businesses even focus on giving them students knowledge and content like AmBoss, UWorld, and Med Online and other sources. So in reality, we have a well-developed system to provide content and knowledge. What we probably have underdeveloped is the focus on building physicians' capacity for language, as I pointed out in 2010 in a letter to Science, but also thinking and reflecting. So we need people to think more about reasoning and evidence, or even centering, coordinating, equipping, and evolving. Hello, I just heard somebody say something. Is there a problem with my slides or presentation? So in terms of composition, what does this mean? Well, in 1994, Perry and Smart introduced the notion of composition as a cognitive learning experience or process that was related to language and making revisions about language and about what you thought. So obviously it can be oral or written. Composing is messy. It needs time to think about it and develop it as a medical student. And it's certainly helped by effort, coaches, scaffold structures, and genres as spaces where solutions can be discovered. So clearly that's where I'm going, and I agree with these people. But there are three central applications, and I just want to point out what those are. So the first thing is that all of our students, if they're going to apply to the United States, need an occupational communication test. So Flaherty in 1982 showed that more than half of medical students were just incompetent or below average on English composition. And these scores predicted clinical competency, really. Now, writing courses have become available in many universities, but the important thing to note is that in 2020, the ECFMG and the ACGME suddenly required occupational English competency to be a criteria to be able to enter the residency match and become a resident in the United States. So the first aspect of composition is that if you're good at composing information about patients in an occupational sense and communicating that to others, then that is going to do you a good thing when it comes to residency matching. And if you want to, move from Sri Lanka to the United States. The second component is, does clear writing, does it affect thinking? So yes, good writing could affect occupational English competency, but is it relevant to thinking? So the key is that one person in 1967 in Canada, as an editor, said, after being a physician, said that clear writing reflects clear thinking and is persuasive, whereas Boker in 2023 said composition is actually a way of being and acting in medicine. So a shift from just doing a good job writing and thinking to becoming a way of being and acting. So unfortunately, research is targeted writing documents and only emphasizes our communication value. And I list a few things here, which we don't need to go into great detail. But the point is that, for instance, for Boker's study, as pointed out right here, right here, is that juniors just simply seem to be more formulaic and less able to synthesize data. So as you migrating clinical experience and clinical training, you pick up skills that are obviously deficient in a third-year medical student. But if a third-year medical student does a good job at composing their presentation to rounds, for example, then teaching and guidance will be better. So there will be positive accelerative gain in a student who actually pays attention to composition. So to me, the issue is more complex in that sometimes types of thinking are required for composition, but composition, on the other hand, may develop these and other types of thinking. So it's kind of like a feedback loop, but it's very confusing. And students must first create a product with good argument and expression before you can even think about higher level thinking. So yes, it's true that thinking is important, but if students are not at the level of being able to present material for which we can actually go into thinking and how to think, then the student's presentation is deficient. And then we have reflecting. And so we have reflective learning, which can be self, group, social media, regular, periodic, structured, unstructured, a combination of things, which could be creative, like performance art, and even a suggestion that we may need to combine several of these elements in order to be able to understand how a student is developing. The benefits are listed here, and I'll come back to those later, so I won't recapitulate them right now. But the point is that there's a lot of potential benefits when students actually have reflective learning. But there are problems and barriers. For example, not having enough time, focusing too much on learning medical facts, being anxious about sharing your thoughts, and not linking your reflection activities, such as writing a reflection about what happened to this patient or how I feel about this or that, or my morals and ethics, how this relates to the ACGME requirements for residencies. So we have three potential applications. We have occupational communication from composition. We have thinking, and we have reflecting. So these are three important components of composition and where it's going. So I know this is a little bit abstract right now, but you'll see where it comes together later in my talk. So there's some examples of compositions, and I don't want to go through all the details of these, but there's patient notes, which are formalized. It can be formalized standard OSCE notes in response to a simulated patient using a rubric, such as here. They can be written, but you can also have patients that you see on the ward that write open-ended notes. And you can even develop some of these as ideal prototypes, like what's a perfect case of cholecystitis or appendicitis versus variations, or you can include variations, which are called exemplars. You also have medical documents. You also have research products, DM students. Our students at the schools have to do in most cases, a research literature review. And so we have research projects. So when we ask for compositions from students, we could be asking about patient notes. We could be asking about documents. We could be asking about research projects, and we could be products, and we could be evaluating those or assessing them. So clearly, those go on routinely in a lot of medical schools. Now, we also have reflective writing, and I'm sure some of you know a lot about these details. The research is focused on what the content is of the writing and not on the depth of that writing. I grade some of these as well as patient notes in the former slide. There's detailed reviews, including approximately 200 articles and published recently. And I list some of the summaries here. The point is there's no consistent guiding principles or summaries for how to do reflection. Reflection is best maybe when it's integrated with other teaching strategies, but we need evidence for that. We don't need people just suggesting that reflective writing is a useful thing and students should do it. We also have portfolios, which are complex, they're difficult to implement. We need to train people on how to do them. So as teachers, they can educate students to make really good portfolios. We have narrative medicine, which comes out of Columbia University. My student is my youngest son went to Columbia University, so I know more about this. Narrative medicine is definitely a discrete discipline and is very serious issue at the present time. One of the major methods is to keep a parallel chart, which describes the events and your reflections of what's happening, while you have a chart, which is the medical chart, in terms of all the facts and how we're managing this case, what the differential diagnoses are, and so on. But there's a lot of barriers to these different things. I list here, portfolios is difficult to implement, structure, teach, and guide. Barriers of training for narrative medicine, compassion fatigue, and needing, your focus is on acquiring facts. You've got to pass your shelf exams, your comprehensive exam, and then your 2CK. So who cares about narrative medicine? because if I don't pass my major exams, I'm going to be out of medical school anyway, and so it doesn't matter. So compositions in summary are typically used in medical training and afterwards. In fact, they're relatively ubiquitous. It's surprising how often we use them, despite the lack of evidence base and a confusing scenario or situation. They're diverse across schools, but they're definitely, many of them are present within a school, like in my schools that I am an assistant dean for. We use almost all of these methods, but they're not coordinated or integrated. And if you're really sort of smart about this, you would try and pull them all together and perhaps produce an integrated, coordinated framework that allows you to assist students to perform a lot better, because you have that framework, then you are just simply trying to meet accreditation or regulatory requirements, which are not necessarily the bigger vision for what we want when we really want excellent medical students. So these methods are also, you know, the medical training compositions are diverse in methods, research, any research support, mapping to intermediaries, like just communication, thinking, reflecting, and so on. They're diverse as to the value of students and those who teach and assess. Like, do we really focus on patient notes, or do we focus on reflection? And if we pick one over the other, why do we do that? Is that a bias, or is that, you know, reasonable? And all of these methods are time and resource intensive in terms of composition. So when I present this, this is my summary figure. So unfortunately, it's not possible to link all of these possible methods of composition, which are listed on the left, through the intervening major concepts of language, thinking, and reflections onto potential gains that you may see. And all of these gains on the right are definitely listed in literature. Like, they claim that if we do more of the kind of thing that I'm talking about, we will see massive improvements in all of these things. Unfortunately, there's very little evidence for that. So the end of the first section, which is you know, summarizing the literature with attention to constituent relationships, is, yeah, there's literature about composition. There's putting that into a framework, which I think leads into thinking about occupational communication, thinking, and reflecting as three core steps. But the problem, even if you go through the examples, is that they don't really meet the criteria of a direct one-to-one mapping. So you can't say, for instance, that if I require patient notes, it's going to improve whatever in the middle, and that's going to directly lead to the result. So this would be like saying, if I make a diagnosis of a patient with a squamous cell cancer, and I apply radiation and chemotherapy, I'm going to give overall survival as a potential outcome. So unfortunately, the medical context is not strongly supported by the evidence in medical education. So now if we move to the second objective, which was sharing scripts to embody clinical ontology, a few slides on this. A script is a cognitive structure or a bundled network of associations that experts develop for approaching patients. We all know we have these, so that's not really debatable, probably, and it's well established in psychology. We have content and organization of knowledge, and unfortunately, even though we activate scripts, we fill in the blanks or toggle values that apply to this patient versus a different patient, and we use these scripts to lead us to further discussion of potential other options for diagnoses. Students just do not develop this. And so they need direction. So they focus on the initial part of history and physical, but when I grade their patient notes, it's clear they cannot compose reasonable differentials, justify them in order to write tests. There are some problems with scripts as mental structures. Now, listed them at the bottom, which you can look at when you look at the slides. But there's a good 30-year summary by Custers in 2015, for example. So the key thing about scripts is that they are personal. So when we take the issue of what we know, we develop a script not because the teacher tells us it, but we develop it ourselves. So in the 1980s, when I was a medical student, I went and saw patients and I developed scripts. You know, what is the prototype for this problem? What's an exemplar which is similar? And what is a set of facts that I need to know? Like, what do I need to ask in the history, the exam? What do I need to examine? How do I pull this together? What predicts the diagnosis, and what tests do I need to have, and what are the appropriate tests? These are the things that the students need to develop. And there are a list, as I mentioned here in the second panel, of methods that can help students do it by forcing them to try these different methods. They won't appreciate these methods. They won't even know about them, but we can introduce them to them so they can develop their personal scripts. And obviously there are barriers, such as they don't see too many cases in clerkships. They have limited team feedback. They develop these scripts slowly over time, and they need to focus really on common scenarios. We don't want to present to them complex scenarios of rare cases because they're totally irrelevant to long-term medical knowledge. What they need to do is to be able to manage the most common 90% of what they're going to see when they graduate as a resident and then move beyond a resident into an attending. Now, the offset of this is that although those scripts in your brain that you develop and you invoke every time you see patients, those, if you share them, are relevant to what's called ontology, which is, as demonstrated in this New England Journal article, a representation of concepts that is far more broad than the way clinicians think about cases. So we have cases on the one hand, and then we have scripts for ontology beyond that. And the interesting thing about this is it's strongly related to medical records and insurance requirements. So the records can constrain and accelerate ontology, but they can also influence or shape or dysmorph personal scripts. So we need to be attention that the combination of scripts as mental structures, which we need to be able to engage patients and think about the predicaments and navigate that either straightforward thing or the confusing scenario where the script doesn't match what the patient is saying or the examination findings don't support. We need to navigate that between the personal scripts and those scripts that are ontological, meaning that they are not just ours, but they are shared by everybody. Now, the next step in the argument to pull this together is to think about assessments. So obviously, we don't just want students to kind of meander and develop how they're developing without us being able to give feedback or assessment. So when we think of assessment, we want to prevent difficulties. We want to assess them for potential difficulties. And then when there's a problem, we want to help them improve or remediate. And I just list a whole bunch of approaches to that, which is pretty standard for any kind of concept of assessing. So I won't dwell on that. But the point is that we position assessments across the entire teaching spectrum. So assessments that are particularly high volume by schools and deans are the things that we need to focus on. So for example, at the R3I, we get about 200 patient notes a week, and each one takes 6 to 10 or 15 minutes to actually grade. So this is taking a half or one dean out of 3 dean complement to actually grade and give customized feedback. Now, unfortunately, rubrics are not great, So we need to come up with strategies to evaluate patient notes and reduce dean burden, but at the same time, improve student formative development and even summative assessment. We also need to think about reflective writing, that every week at R3I, we get several hundred, but slightly fewer patient notes. And we need to think about what is the reliability and validity of an individual dean looking at a student's reflective writing about an aquifer case or a case that they saw during the week and commenting on the ethics and the dilemmas and anything else that they learned, and is it helping them improve their competencies? So there's a reflect rubric, and I quote, Wall 2012 here that you can look up. But the point is that RW, or reflective writing, requires a lot of examples and a lot of raters. So it's really more formative. So when I'm grading students' submissions for reflective writing, I'm not having other deans review it. And so in consequence, the focus is on really, can I make the person think more about reflection and improve their process for reflection, rather than assessing them as how good they are at reflective writing, and is it valid, is it reliable and valid? Now, the last thing I want to talk about, because it's been brought out already in prior discussions, but there's obviously a significant potential impact of artificial and augmented intelligence, which I call A2I, which is consistent more with what the NBME and the U.S. organizations support, and also machine learning models and natural language processing. When we think about assessment, so I've been involved in this, as I mentioned, at the beginning. So I just want to point out a couple of major points to this, and then I'll stop talking. So compositions as I've listed them, which is a range of oral and written products from students. They may also include students working with other people to produce a product. But those compositions can be inputs for automatic grading and assessment, as well as augmented intelligence to help a dean. And this was covered kind of in a prior talk, just a couple of talks ago. Now, it does require coding and text, and Clouser in 2024 just published just a month and a half ago from the NBME, actually points out, addresses the issue of short response answers, which is text. So you're not really looking at multiple choice questions, true, false. You're looking at text, which includes patient notes, personal reflections, and everything else that I've mentioned already. Now, the two main approaches to this are text mining, such as, for example, does this patient note have a family history section? If it doesn't, it's deficient. If it does, and it's a requirement, then it's there. And what are the contents? And then you need similarity indices, which is this a pretty good note compared with all our students, compared with an ideal note written by deans, for example. So we can use text mining and similarity indices, which are well developed now. They're available. But the problem is that AI and machine learning are not yet ready to deploy because they're subject to biases, as the previous presenter mentioned. My research is on OSCE patterns, patient notes, competency, other reflections, and even research proposals and papers, like an entire paper that is a research production. Like, here's my 5 papers addressing this hypothesis. Here's my summary. Does this actually address the hypothesis, and can we make a reasonable conclusion? So my current research is on all of these aspects. Now, Janney et al., which includes me, in 2021, cited in the NBME Clouser 2024 paper, and then a couple of others have pointed out risks. And I just list a few of these here, which have already been partly mentioned by previous presenters. But my ultimate issue is, can we get the AI strategies to help build towards and grade core competencies and even the milestones? So if you go to the AGCME and you say, what are the core competencies? All 6 of them. You go to the CAMMEDS 2015 and you say, okay, give me the list of 87 or so sub-competencies that I should be able to grade when I'm thinking about the student. And then when you go to the milestones, which are scoring from less than 1 to 5 on how students are doing on these 20-odd competencies and sub-competencies, could you get AI to do that? So one of the preliminary studies that we did, and this is important because a lot of people talk about AI, but they haven't done actually any research. Here we actually looked at OSCE flow. So my medical student son in before radiology, but at Columbia, and a couple of other people who actually had training and work at Google, but became medical students. We combined that, and then I combined my statistics to develop an analysis of what happens when a OSCE happens. So this is not a patient note. It's just the OSCE is 2 interacting people, a simulated patient and the medical student. And what we want to know is, are they performing at a reasonable way so that the pattern of their interaction with the patient is acceptable and they're acquiring the data that they need to do, and they are meeting the requirements of the OSCE, such as they have sufficient numbers of open questions versus closed questions. They put the things in the correct order. So we came up with a machine learning solution which looked at the pattern and gave visual feedback. And I created this graph, which is shown on the right here as figure 3, to show that you introduce, the golden stuff on the left, you introduce yourself, and then you ask some general questions, and then you start focusing and narrowing down. And when you get to the pink and red areas, you're asking specific questions about meds and allergies. And then as you move forward, you start to think about how to formulate this case. And then you do your physical examination, which is in purple. So what this shows is that there's a few things that are a little anomalous in this person. The light blue is presented within the first few utterances of 10 to 15 and then reintroduces itself as at 45 or 50. Like, why? You also see on the far right that this student spends 66% of their time or so talking and only 33% of the time listening. And so what you see is the student talking on the top, which is classified as to what they're talking about, what they're asking about. And at the bottom, you see in this case, just ghost limited statements and summaries and conversation from the patient trying to answer the question.
Excuse me.
What we show
we're running out of time.
Yeah, what we show is that it's possible to use machine learning to give direct feedback to students to improve their clinical skills towards an OSCE. So just to quickly in summary, the composition is a useful integrative concept. It's typical when learning basic science and clinical science. It clusters a diverse set of parts of teaching and assessment. So in a sense, it's an organizing concept. If you think just about writing and speaking, that kind of atomizes what we're really talking about. Composition is more important. Some authors conflate composition with clinical reasoning, profession, and competencies. They make basically composition the equivalent to everything else, in which case there's no distinction, and composition is equal to everything else, which is kind of pointless in terms of conceptual thinking. And research is limited or null or confusing in that there's a lot of published qualitative and subjective comments about compositions and how they relate. But the reality is there's very little evidence, as I've kind of summarized, in terms of effectiveness and relationships. And scoping reviews are increasingly occurring, but we need more research. So the last point that I want to make is that we have the potential to abandon what we're doing and move towards a more revolutionary approach to understand what is actually happening and to measure things at a higher level. But we're not there yet. So the approach would be to use text mining and similarity measures and leave AI and machine learning for future development. And maybe in 2, 5, or 10 years, we'll be there. But at the present time, our primary focus is on what the NBME paper in 2024, a couple of months ago, argued, and what I've been pursuing for 3 or 4 years, is that we focus on text mining and similarity indices. So that's the end of my presentation. Thanks very much.
Thank you very much, Dr. Jones. I appreciate this interesting look at how we learn and how we communicate in medicine. And I think, though, it would be very interesting to do some studies on that to see if your hypothesis is correct and if indeed AI can assist. However, I do think telling how you tell a story does improve how you get the message across to the consultant or your colleagues, and how to have a better understanding of how the disease process unfolded. Are there any questions for Dr. Jones? I think we have time for one question before the next session begins. Anybody in the text? You can either write it in the text or unmute yourself. Okay, Dr. Jones, thank you very much for enlightening talk, and have a good evening.
Yeah, sure. And if anybody wants to email me, as I said, it's g.jones@saba.edu, and I'm quite willing to share the material and the references, but also, address any questions that people have. Me and my sons and other people are actively involved, and we're cited by the NBME in just the last 2 months. So obviously we're doing a good job. And we're at the cusp of what we need to be at. So if people want to know what our impression is or our perspective, please let us know, and we're quite willing to share it, and especially because I'm an academic. There's no commercial aspect to this.
Sorry, the host was not permitting any questions when I was trying to ask a question.
Okay, could you put it in the text for me, please? Because we have to really move on to the next session.
Okay, I will do that.
Thank you. Dr. Indira Grimes will now come to host the fourth session, sorry. Dr. Indira Grimes?
Hello, good evening, everyone. Thank you very much, Dr. LaVille. Welcome as we prepare to begin session 4, entitled Mental Health and Wellbeing for the UWI SCMR Research Day 2024. We have a slight change in the program. So for beginning this session, we will begin with Dr. Wesley Francis. Dr. Francis is a graduate of the University of West Indies, Mona. He did his surgical residency at Wayne State University in Detroit, Michigan, and completed a surgical oncology fellowship at Tom Baker Cancer Center in Calgary, Alberta. He is currently a consultant surgical oncologist at the Princess Margaret Hospital. He is presenting us today the topic survival analysis of breast cancer patients in the Bahamas, insights from a population-based registry. Welcome, Dr. Francis.
Hello, hi. Thank you, Indira, for that warm introduction. If I can get ability to share, I think I should be able to. Can everybody see my screen? Yeah, okay. It's just well, thanks to the program coordinators here for allowing me to give this talk. And this talk came out of the registry. It was supposed to be done overseas, and so we added it also for the local audience. And so it's about survival analysis of breast cancer patients in the Bahamas from the registry data. And so we got some insights from our population-based registry and thought that we should share those. So in terms of introduction, as everybody knows, breast cancer is the #1 cancer affecting women in the Bahamas. And it's the leading cause of cancer-related mortality worldwide. A population-based registry was started in 2018 in the Bahamas, and this is known as the Bahamas National Cancer Registry. Prior to that, all we had was a hospital-based registry, but we got a stakeholder group together, got a legislation, and this brought in the registry. After the legislation was passed, it still took some time to get the registry started, but the registry started collecting data in 2018, and they then collected prospectively, did not go back. So all the data in the registry started in 2018. So the aim of this study that we did was basically to review the registry data and look specifically for survival trends in breast cancer patients. And our primary endpoint was to calculate overall survival. That's all-cause survival or death from any cause. And what we did was we looked at all the patients in the registry who had a breast cancer diagnosis. This is a retrospective review because we did this earlier in the year. And we looked at demographic data, age, gender, and looked at the date of diagnosis. We then took the registry data and compared it to the registry information from the Department of Statistics. The Department of Statistics has a death registry, and so anybody who dies in the Bahamas is put in that register. So we then compared our database with that database, and we looked to find out how many of the patients in our registry actually had died. And so if those patients had died from any cause, not just breast cancer-related death, because it would be difficult because not all of the patients would have the real cause of diagnosis. So we looked at all-cause mortality. And so we then used that information to calculate a survival time in months. And so the survival time in months was calculated from the date of diagnosis, which would be in the breast cancer registry, to the date of death, which would be in the death registry. And so we took all that information and we used SPSS version 23, and we were able to calculate a survival function and then calculate and plot the survival curves using the Kaplan-Meier technique. And so in terms of our results, so a total of 960 patients made up the study population, and all of these patients had a diagnosis of breast cancer. And the duration of study was from the outset of the registry to March of 2024. And that's when we did this study and was able to determine, or that was the study population. So we had 960 patients, 948 were females and 12 were males. And the median age of this group was 57, and the range was 25 to 94. Yes, we had a 25-year-old, and we also had a 94-year-old. 68% of the population was over the age of 50, or what we deem postmenopausal from a clinical perspective. And the majority of patients were between the age of 50 and 60. So it was a evenly distributed curve, but the majority of patients were between 50 and 60. So at the time of review with the deaths registry, 22% or 213 patients had died. And again, the death was from any cause. It wasn't just breast cancer specific survival. or mortality due to breast cancer. So from that, we were able to calculate the mean survival time to be 62 months. And that's the mean going across the entire group. But the median survival was not reached. And I will explain that in a second with the curve. But the overall survival, or overall 5-year survival, was calculated at 74%. That means for that cohort, it was estimated based on Kaplan-Meier techniques using SPSS that our overall 5-year survival was 74%. So this is the survival curve that was plotted. And this is a Kaplan-Meier curve. This shows the percentage of patients surviving. So it always starts at 0 and it's 100% survival. And this is the survival time that was plotted. And the survival time is from the date of diagnosis to the date of death. Date of diagnosis was in the cancer registry, date of death in the death registry. When you look at these curves, the median survival occurs whenever the curve intersect the 50% line. And as you can see here, this does not intersect the 50% line. And that represents when 50% of the people within the cohort dies, or, I mean, if you're half full, half empty, either 50% has died or 50% still alive. And so we use that as a metric to say median survival for breast cancer is X. So in this cohort, we never arrived at the median survival. So when you don't have the median survival, you have to use the mean survival. And the mean survival, as you can see here, was 62 months. But then we used the survival curve to estimate the 5-year survival, and that's at 60 months. And as you can see here in this curve, our 5-year survival was about 74%. And so right here. And this is how Kaplan-Meier curves is used. And again, remember, this is overall survival and not breast cancer specific survival. Overall survival tend to be higher than if you have breast cancer specific survival, because people in this curve, they die from any cause. So from the registry, which was developed in 2018, and again, it was to collect data on cancer within the country. From this research, we were able to show trends and incidence or demographics for major cancer affecting the Bahamas. And that's all in the cancer registry data. So true breast cancer survival data had not been previously published using a population-based registry. We always had some survival data, but it was always based on either personal cohorts that people had, or I think there was one where we'd estimated based on the registry, the hospital-based registry, but we never really had a population-based registry to be able to estimate survival in any cancer. And this is the first time we were actually showing, and the data had to mature a bit for us to be able to show population-based survival data. When we look at US, and I specifically pulled this out, and this is the SEER database, and we in the cancer registry aspire to go to the SEER, to be like the SEER database. And I was able to pull this information off their website. And this is the survival curve for Blacks, including Hispanics, all ages, all stages, just equivalent to what we have. And this is overall survival. And you can see, whereas ours was about 76 in the US, the survival at 5 years for breast cancer overall, this is in Blacks. In whites, it's a little higher, but I wanted to match the population, and it was 81.2%. When we look at breast cancer, I just wanted to share this data, which is our incidence rate per 100,000 females in our registry. And we can see based on the different year from when it started, to 2022, and usually registry data are at least 2 years behind. You can see the breast cancer incidence showed here in this curve, and then in this bar chart, and you see we started off at 106 per 100,000 women, and gradually we saw a fall, and I believe COVID had to do with this, and I suspect that 2023 and 2024 data may be a little higher. But this is the incidence data that we have. So this study reports the overall breast cancer survival 5-year to be 74%. It is definitely comparative to US SEER database, which reports overall survival in Blacks, including Hispanics, to be 81.2%. And when you look at global trends, and this is data published in American Journal of Cancer Research, you can see 5-year, again, overall survival, not breast cancer specific survival, but overall survival in South Africa, Algeria, India, and Brazil. And these are countries with robust data, and you can see what their 5-year survival, overall survival would be. And compared to ours, we are actually doing very well there. What's the limitations of this study and what are future considerations? Certainly with any administrative databases, and here we were using two. We're using the breast cancer registry and the death registry in the Department of Statistics. Administrative databases always are sometimes fraught with errors at times. And so obviously you have to review the data, understanding that it's an administrative database and it could be subject to error. It's retrospective. Something I think we could get better data if we did a prospective study over a period of time. And then third, in terms of future considerations, we were not able to do subgroup analysis because we just did overall all-cause mortality and all stages. But if we looked at subgroups, for example, to be able to look at different stages, to build that out, look at different subtypes, whether they're hormone positive, whether they're hormone negatives, HER2 positive, triple negatives, all the different subtypes, I think that would be a more meaningful data that we can actually use. And other risk factors that are associated with development of breast cancer. So in conclusion, so the Bahamas compares favorably when it comes to breast cancer 5-year survival. I think, we have a robust, I believe, treatment, even though there are some issues with it. But patients with breast cancer do get multidisciplinary treatment. There may be some delays and maybe some issues, but they still do. We do not have a national screening, and a screening for us is opportunistic. But with all of the programs going on, sufficient women, I think, do get screened. Can we do better? Yes, we can. The registry is in place, and it's important for planning purposes. Incidence, mortality, survival statistics are essential for resource allocations and future development for a comprehensive cancer control plan. I think with this study, this is the beginning of many, start to give actionable data that the ministry and other planning organizations can use to then evenly or appropriately distribute resources to the areas that need them. We did this with breast. It can be similarly done with colon and any other breast cancer, and any other cancer, prostate, ovary, and uterine. And that's the conclusion to that. Thank you all for listening. I will entertain any questions.
Thank you, Dr. Francis, for that very important and informative talk. Do we have any questions for Dr. Francis at this time?
Yes, I do have a question. I would like to ask Dr. Francis. There was an initiative with HIV patients. They get medications free or at lower cost. And so it has had a positive impact on HIV patients. Is there a similar initiative that could be put in place for these cancer patients?
I mean, the answer, I don't think so, no. But what I would say is that the public sector, I think patients do have access to cancer care. They have access to screening. They have access, once they have a diagnosis, to be able to access services in the public sector. Our public sector, our oncology clinic actually is a multidisciplinary clinic. And we do spend time doing multidisciplinary discussions at our tumor board surrounding patients. And I think it's the only forum where cancer patients are really discussed in the Bahamas like that. So it's available. I mean, surgical oncology, medical oncology, radiation oncology, all of these services available within the country. And one of the things that I think it was a part of a long time ago is putting together a cancer control plan, and when I think it was the WHO looked at the different elements of that. And one of the aspects that we did well on was the therapy aspect, because we had medical oncology, we had surgery, we had radiation. Where we fell off was not a proper screening program or a national screening program, or where we fell off was on the tail end, which is rehabilitation and hospice. And we were found to be lacking in that. So I guess to answer you in a roundabout way, I believe that patients with breast cancer specifically and other cancers do have services that they can access so that they can get treatment. And if you look at this, and if you say 74% is decent compared to other countries, comparable countries, middle income countries, it is really because we have these resources in place that patients could access.
Thank you, Dr. Francis. Do we have
Good night.
another?
Good night, everyone.
Go ahead.
Good night, everybody. Thank you, Dr. Francis, for a very insightful presentation. I want to congratulate you because it is heartwarming and inspiring to see, to be present from the very beginning as a stakeholder in getting the registry off the ground, and now being able to see the actual fruits of that and what it can actually do and show us, and how impactful it can be in terms of, planning, resource allocation, and the like in the country. And I just wanted to say, it's not a question, but it also highlights the fact that if you put the information in, you can get what you need out of it. And I'd like to encourage all of the physicians, all of the entities to continue to provide the information requested regularly to the registry. That's how we keep current and updated. So I thank you, Dr. Francis, and it's very exciting, very, very exciting to see this. Very, very exciting.
Thanks, Tracy, for that comment. And again, just to reiterate, I mean, the registry is only as good as the information that it gets. And so everybody has to participate. And then we can have a robust registry. And it's if you give us data, you will then have data for your research. It's open to everybody. I mean, we don't discriminate. You come, you request some data, and you actually get it. So all the practitioners who want to use this information to advise patients and all of that, again, please, you have to support the registry, and the support is by giving us data.
Indeed. Thank you, Dr. Francis, once again for your talk. And we certainly will do our endeavor best to support the registry. Very important work. Continuing on in our session for session 4, in mental health and well-being, we welcome our first keynote speaker, Dr. Kayon Donaldson Davis. She comes to us from Mona Aging and Wellness Center, where she has worked as a lecturer since 2018. She's a medical doctor, having graduated from the Faculty of Medical Sciences at UWI Mona in 2010. She has worked extensively in Jamaica and the British Virgin Islands in the areas of urgent care and community medicine, with a passion for public health, primary care, and the care of older adults. She is a trained public health practitioner with additional postgrad training in gerontology and medicine for the older adult. Dr. Donaldson Davis has worked with Professor Denise Eldemeyer-Scherer and the Mona Aging and Wellness Center team since its inception in January 2021, when the newest geriatric training programs for medical doctors were in development. Her research spans the disciplines of public health and aging, with foci in the impact of COVID-19 on older persons and long-term care provision in Jamaica. She continues to provide clinical care for older persons as a general and aging medicine practitioner. Dr. Donaldson Davis is married with 2 daughters, ages 14 and 9 years. She is the current head of the postgrad diploma program in geriatric medicine at the University of West Indies, Mona, and she's here to present on innovations in healthcare for the aging population, an age-friendly approach. Welcome, Dr. Donaldson Davis.
Thank you very much, Dr. Grimes, for that kind introduction. Are you guys hearing me very well?
Yes, we are. Thank you.
Thank you very much. All right. So today's talk, when I realized that we were doing, I was presenting in the mental health segment, I spoke with the organizers. And so it is my pleasure to speak with everyone today about abuse and neglect of older persons, which is one of those cross-cutting issues that really spans not only disciplines, but it also spans the breadth of issues that can be faced within the community, within an institutional setting, and in healthcare and outside of healthcare setting as well. So it is my pleasure to be here. As Dr. Grimes said in my introduction, I'm from the Mona Aging and Wellness Center, and it is indeed a pleasure to be here at the 17th Research Conference for the UWI SCMR. So in terms of an outline for today's presentation, we'll be just looking at some definitions and categories initially on abuse and neglect, looking at some risk factors as well, ways in which abuse can be detected during older adulthood. We're going to look through some of the challenges and best practices in addressing abuse across the Caribbean. And we're also going to look briefly at some recommendations for future action. So in terms of definition, due to its complexity, elder abuse or abuse has been very difficult to define. Older persons throughout the world have the right to be treated with dignity and with respect, and to be given the best possible chance at a happy existence and a sense of well-being. But abuse is something that comes up quite often. It isn't very well documented, and we don't capture a lot of data on it. But let's start with some of the basics. So it is the single or repeated act or lack of appropriate action occurring within any relationship where there is an expectation of trust, which causes harm or distress to the older adult. There are several ways in which it can be done. So there are acts, what we call acts of commission, where something is actually done to the older person. They are wrong, they are harmed in some sort of way, or acts of omission, as the definition speaks to. So we're talking about features of neglect here. ignoring certain things or withholding certain privileges that the older person should have, especially those who are especially vulnerable, those who have disabilities or cognitive decline, or those who have sensory deficits and so on, persons who are immobile and bedbound, etc. So in terms of the categories, it can occur in two main settings, as we said. So it can occur within the home or community environment, in which case we consider those domestic types of abuse. It can occur in the older adult's home or the home of the caregiver, but it is usually somebody that's close. In a similar way, when you hear the talks about child abuse, somebody who's a relative or close friend, and even in situations where they have a paid caregiver, it can occur as well. It can also happen within nursing home setting or any other type of long-term care setup, so a care home or group home setting. But it's usually a situation where the abuser is paid or has a sort of contractual agreement to look after that older adult. No, the classifications, I mean, I know I don't need to expound too heavily here because we are familiar with physical abuse. So by physical, we mean the hitting, the slapping, the pushing, the unnecessary use of restraints, the force feeding, the forceful brushing of the teeth, that sort of thing. Sexual abuse, non-consensual or coerced consensual sexual activity, rape, sexual assault, etc. The psychological abuse, which is the hardest one, I think, especially because the signs of it can be very subtle. Individuals may be under a great deal of emotional distress. Humiliation and blaming and intimidation are all forms of psychological abuse. Name calling, or even belittling the individual and making them feel small or like they're a child, especially when there is a physical component, so the individual is not able to physically put up a force against the caregiver themselves. Okay, there's also financial and material abuse, which again speaks for itself. The theft, the fraud, the exploitation. Sometimes family members try to access the assets of an older adult, their pension, their income, even the property, sometimes gaining, financially for themselves and not necessarily pouring that financial gain into the care of the older adult themselves. We see this come up all the time. Under the financial and material abuse comes the category of scamming or scheming against older persons as well, which I'm sure we all have heard about, the lottery scams, etc., where a lot of older persons, especially in the North American setting, tend to be targeted. Then discrimination is another type, acts that are against older persons just by virtue of their age. It may overlap with sexism and racism as well. Neglect or abandonment is another important type of abuse, and this, as in the earlier definition suggests, it's when somebody refuses, whether willingly or unwillingly, whether knowingly or unknowingly, to fulfill any part of their obligation in terms of duties to an older adult that may result in harm of that older person. Now, self-neglect is one category or classification that we don't often hear about. I put it on this slide because I wanted to bring attention to the fact that it is an abnormal behavior. So when you see an older person who is not caring for themselves, not meeting their hygienic needs, not taking their medications, not, it should come off as a red flag. It should ring home to you because it is not normal behavior, and it's usually a sign that there is something to be addressed, whether there is a socioeconomic issue that needs to be handled, and that they're not managing. or there's a cognitive issue or some sort of physical or intellectual disability at play. So it should never, ever be overlooked. We don't expect to see an abuser. We don't expect the usual type of penalties to occur, but it's supposed to it is very important because it usually signifies that this is an older adult in need. Now, neglect and abandonment is something that Caribbean countries, everyone, I think all of us have had to grapple with. It has gained a lot of attention in the last several years, I'd say maybe 7 to 10 years, because of just the different types of abandonment we see. We see it in the community where persons may even migrate overseas, leaving their older relatives behind, quite likely with good reason. So the intention is not necessarily bad, but it's just that sometimes these older persons within the community really struggle, in terms of meeting their needs. Also, we have that issue of institutional abandonment, persons who may have, older person, for example, who may be active and very robust and strong and physically, doing fine. Prior to a catastrophic health event, medical event, they fall, they break their hip, they have a stroke, etc. And then beyond that, become immobile and have significant care needs. Sometimes family members do not know what to do in those situations, how to manage it. They might outstretch their financial capabilities, and therefore those persons are left in hospital. Another common reason is, for persons who are struggling with cognitive decline, sometimes when the behavioral and psychological symptoms become very pronounced, persons get aggressive, and family members sometimes do not know how to navigate that and may leave their loved ones in hospital as well, or in a nursing home setting with no minimal to no contact. So I've outlined some of the medical as well as some of the social reasons behind abandonment, which is brought out on this slide as well. All right, in terms of the extent of the problem, sometimes it's a bit difficult to quantify because naturally underreporting is a significant issue. Some people are made to feel as if they are being threatened, and therefore they are less likely to report. Also, older persons themselves, there's a physical component, going through the motions, reporting it to the necessary law enforcement officers or social workers. They may have to go out of their way, and sometimes they're in a community or long-term care setting and they are not able to do so. But there is data from out of developed countries like North America as well as Europe. The World Health Organization in June of 2024 estimates that there's a 1 in 6 prevalence, or 15% prevalence of all type abuse against older persons 60 years and over in the community. The rates tend to be higher within the institutions. We're looking at 60+%. And since the COVID-19 pandemic, that number has also increased. And with population aging, which is the increase in the proportion of older adults within the world and in developed countries like our own in the Caribbean, we are expecting that the cases will also increase, even if the proportions don't actually increase, just by virtue of the number of older adults we have to grapple with. Now, just to bring your attention here on this slide that breaks down the different types of abuse. So we see the all-cause prevalence as well as the prevalence of the different types of abuse, just to show you that psychological abuse tends to be the highest or the most prevalent in the community setting as well as in the institutional setting. Now, in the Caribbean, we don't have as much organized data in and around types of abuse. We have some published data. Some countries have managed to publish. We have unpublished data, and we certainly have a lot of references within the news or the media space. So in terms of published data, we see where the government of St. Martin estimates that emotional abuse among their elderly is at about 4.1%, and financial abuse is at 3.6%. The Mona Aging and Wellness Center in Jamaica, the research team there did a small study within the gynecological and urology clinic. I think this was in 2013, and they were looking at older women, 50 years and older, and what they found was that there was a 23.5% prevalence of a report of having had one forced sexual encounter in their lifetime. And among that 64 women studied, 11% of them indicated that it had taken place within the last year. Now, while we recognize that this is a 50+ age group versus the 60+ age group that we are really referring to, you know, it is just very important for us to note the prevalence in this middle age to older adult age group. Now, with respect to news, we see, like I said, you know, there are several references within the news space, and this is not to make anybody look bad, because in preparing for this presentation, there were several, I looked up, you know, news items from several different countries across the Caribbean, and for almost every country, there was something to be reported and said on abandonment or elder abuse and cases that have come up in, you know, across the region. Now, looking at risk factors, just to you know, just to go through them quickly, clearly there are characteristics within the older adult population that makes them certainly more vulnerable. So we're talking about those with frailty, those who have cognitive impairment and living with dementia at either mild, moderate, or severe stages, those persons who are financially dependent on their caregivers. So they're in a situation where they pay for everything and they, you know, essentially they are just catching. Those persons who are socially isolated, maybe living in remote communities, are also sometimes lack the avenues or don't know the avenues to turn to when they are faced with these situations. Then there are caregiver characteristics that we have to keep in mind. And this is the reason we're going through these risk factors, is that sometimes when you see them in the clinical setting, it should pique your attention. So caregivers who are highly stressed, burnt out, you know, having significant caregiver burden, right, are at risk of abusing. And remember that a lot of caregivers out there are older persons themselves. So we're talking about looking out for the group of older persons who are being abused and looking out for that group of potential abusers, older adults who are potential abusers as well, right? So looking at it from a prevention standpoint too. Those with mental illness or who use substances or abuse substances, persons may have a bad relationship with their care recipient or just financially dependent on them as well. And, you know, it becomes a situation, a threatening type situation. The law and governance of countries as well plays an important role. So if there is no specific legislation surrounding older adult abuse, then, you know, there may be no, that usually sets the framework for everything else, right? To follow through the case investigation, the law enforcement officer engagement, and the follow-up, and the, you know, taking it to the point of the, you know, taking it through the judiciary system. Sometimes there are laws, as you will come to see. Some countries are far advanced and do have laws, but there are issues with the enforcement of the laws. And then, of course, there's monitoring, and we're talking about within the community as well as the nursing homes in and across each country. Institutional issues arise, or risk factors arise as well. So the staff may be poorly trained to deal with certain things. So some of the behavioral and psychological issues, they don't know how to handle it, and then they get frustrated and, you know, restrain the person unnecessarily. Some facilities are ill-equipped. Some persons are dissatisfied, not being paid adequately, working long hours. And then, of course, the systems of accountability within the institutions play a role as well. Societal values are also something to consider. You know, how do we value our older persons within the community? What do we teach our children? How do the young adults interact? Is there a lot of interaction between or engagement between older adults? It is what we call intergenerational engagement, so that there is a true appreciation for the older person. Sometimes too, caregivers are burnt out, as we mentioned, and they have nowhere to turn. They don't have respite care services. They don't, and most importantly, sometimes they're forced to leave the workforce to look after their older adult relatives. And many times they don't have a way to supplement their income, and therefore things get hard. The financial crunch is felt, and people, may take out their frustrations in different ways. Now, there is this issue of transgenerational abuse that I want to bring up here just briefly. This is where violence is learned through familial exposures and experiences. So a child who was once abused by their parent may continue the cycle of abuse. When they are older, they may abuse their children as well as the older adults or anybody who is vulnerable in their space. So, this is the sort of thing that we need to acknowledge. Sometimes it requires some introspection and getting help for ourselves if we see where this is something that has impacted us personally. So detecting abuse, just like, we're detectives in terms of, diagnosing other illnesses, it starts with the history and physical exam, just to go through the fact that never ever underestimate what the patient is saying, even if there is dementia or cognitive impairment at play. You may need to engage others, for collateral information, neighbors, family members, persons who visit or do home visits, whether the nurses, or social workers, anybody, occupational health specialists, environmental specialists, anybody who interacts with the older person regularly enough may be able to piece a puzzle together. Look out for features of caregiver burnout and try to call it out where it lies and encourage the persons. Offer your own services or direct them to places where they can, air their own grouses, get their own health issues sorted out as well. Try to be delicate as you try to investigate these cases of abuse. You don't want to put undue suspicion on well-meaning caregivers, because sometimes the caregivers actually mean well. They don't necessarily intend to harm, but because of the stresses, because they're tired, because they're turning too early throughout the day, at night they may sleep for 5 hours just to get a little concentrated sleep in if they're the main caregiver. And sometimes the person may have a bed sore because they haven't been changed overnight, and these things don't happen deliberately, right? Indicators from the history: unexplained injuries, past history of frequent injuries, and that the point that follows that is recurrent visits, for example, to the ER for similar injuries. So those things should send off some red flags. These are basically red flags. Caregivers that kind of call names, accident prone or clumsy, telling you that the older person is clumsy or they're accident prone sometimes is a little bit suspicious. Sometimes when there's a long delay between the onset of medical illness and when they actually go to seek attention, when they come and the infection is so bad, or they have so many pressure ulcers, that you wonder, why is it that it has taken this long? Sometimes there are issues with adherence to medications, and this may lead to us to be suspicious of situations of abuse. Now, medication adherence doesn't equal abuse, but it should raise a red flag, especially cases where persons arrange medications for their older care recipients. Exam findings, the typical ones: anything, bruising in atypical locations, especially on the ears, the neck, the face, etc. Patterned injuries like bite marks or, buckle-shaped marks, rope marks, fingertips, scars on the wrists or ankles, burns, multiple fractures, subconjunctival or vitreal or retinal hemorrhages, soft tissue injuries in the mouth, broken eyeglasses, and changing of the hairstyle or the clothing or the style of dress to cover up bruises. Pressure ulcers, as we mentioned before, is a sign as well. It doesn't equal abuse, but it should raise your attention to the fact that they may not understand the care provision situation well enough. Exam findings also extend to sexual abuse, the genital, rectal, or oral trauma, evidence of an STI, also persons who are being neglected, maybe cachectic, dehydrated, they may have poor overall hygiene, and this reflects in the toenails, the fingernails, the clothing, etc. Your documentation is very, very important and an important step in the management. You have to comprehensively document and sometimes even consider taking photographs of some of these bruises because your records may be used for investigation and prosecution. So if you suspect it, you need to start to be circumspect in your capturing of information. The management can be very tricky. It's a lengthy process. You really do have to be vested. It requires a multidisciplinary approach. The doctor alone is not enough. The nurse alone is not enough. It is an entire team that spans both the health and the non-health team. So, this is the sort of thing that you have to really plan for and organize within your setting. Now, just to go through really, really quickly some challenges that we face in addressing the cases. I know sometimes the patient load in the clinic setting is very heavy. Sometimes doctors change, there isn't an establishment of trust because persons may come to a clinic and see different doctors each time. Sometimes there's practitioners just don't know how to handle situation, may not be trained well or just have a limited amount of experience. There's also inadequate monitoring of the residential care facilities and the standards that are set within the facilities may also be lacking. Best practices though, as we come close to the end, there are countries in the Caribbean that really are an example and that have set up at least national aging councils, even if not specific to abuse of older adults or elderly abuse, but they have these national councils which provide an outlet for persons to engage with staff or a team that will put something in action. There may be countries as well, or there are countries, I should say, that have policies and legislation which are specific to abusive situations. And then there are countries too who make access to healthcare setting more accessible, just so that persons can feel comfortable within the space. Because the truth is that an older adult is more likely, or more of the older adults are more likely to interact within the healthcare setting than any other. And they may do so once a year, twice a year, but many of them, many more times than that. So it gives them an opportunity. Here are the countries that have set up national policies and laws that protect older persons. And we applaud the effort and the strides that have been made over, between 1999, when some of the earlier, 1997, sorry, when some of the earlier countries stepped into the 2000s and up to 2026, where persons are still, coming on board with their policies and laws. There are no specific laws to older people in most countries, but like we said, strides are being made. In terms of the Caribbean best practices now, there is a growing appreciation for things like World Elder Abuse Day, which is celebrated or recognized on June 15 every year. There are formalized services, for example, the establishment of hotlines. Within certain Caribbean countries, there are councils and centers. So in Trinidad and Tobago, for instance, there's the Older Person Information Center. In Jamaica, the National Council for Senior Citizens. And there are several of these similar types of bodies throughout the Caribbean. Some countries have even made the bold step to have specific legislation targeting all elderly abuse. So in Bermuda, Anguilla, Trinidad and Tobago has made some strides, but it hasn't been enforced as yet. And Jamaica has the Maintenance Act, which is not an elder abuse act, but it is a basis on which persons can be held accountable. It is an act that centers the obligation on spouses to take care of each other, children to take care of their parents, and parents to take care of their children as well. So the last two slides just speak to recommendations, right? We would like to continue to see countries, governments sign on and to design specific legislation to focus on older adults. We would like to see research driven from within the healthcare, social work, law, physiotherapy. I mean, this issue, like we said, is cross-cutting and spans several disciplines. We would also like to see more education, more public campaigns on world elder abuse day to bring more awareness to different parts of the generation, different parts of the population. We would like to see more training and continuous medical education for health workers in the areas of geriatrics and gerontology, in which case they will definitely be sensitized to elder abuse. Training too of non-health workers, for example, the bank staff, to pick up warning signs of abuse. We also want to consider the incorporation of screening during that primary healthcare visit, just asking the questions, getting acquainted with some of the screening tools that are available, looking at improving the monitoring of residential care facilities, looking at provisions, and we're talking meaningful provisions for as caregiver support, especially when they have to leave the labor force to take care of their loved ones and lose their income. Empower older adults, and this is the last point, but is by far the most important. Empowering our older adult relatives to recognizing situations when they are being abused or are at risk of abusing themselves. So focusing, like we said a few slides ago, on prevention rather than having to deal with it as an overwhelming issue when it happens. So final slide on summary. Abuse of the older adult is of public health concern and is likely to increase with population aging in the Caribbean. The numbers are you know, globally, the prevalence is estimated at 15.7%, and these absolute numbers are likely to increase with population aging. It's common in the Caribbean. Neglect and abandonment issues are especially common. Persons within the healthcare setting, regardless of their specialty, should be aware of abuse and the red flags that are, you know, that we talked about today. Older adults should be empowered, and we are looking at an issue that requires a real solid team approach in order to tackle it. Here are my references, and I thank you very much for your attention today.
Thank you, Dr. Donaldson Davis, for a very timely and thought-provoking topic. As we have recently been faced with some very glaring examples, unfortunately, of older person abuse in our community of late. So do we have any questions at this time or comments for Dr. Donaldson Davis? We can take a couple. Dr. Davis, I wanted to ask, does ageism play a role in the challenges faced in recognizing and combating elder abuse?
Absolutely. I mean, that is where we get to the conversation about the societal values, you know, people, how they view older adults, how they even deal with some of the normal changes that occur with the aging process, you know, how compassionate persons are with some of the health issues that persons may face as well. Are they willing to even find out about it? Do they just put it down to aging and, you know, leave the older persons to fend for themselves within the community? Ageism is a big deal. It leads to neglect. It leads to discrimination. And nearly all the forms, is a lack of respect as well that comes out with this, with the ideology of ageism. It does play an important role. Thank you.
Thank you as well. So just happy to hear all the points you made, and hopefully we will be encouraged in the healthcare fraternity to push for strengthening of legislation to guide us with protecting our older persons as we move in the future. I was particularly also enlightened by the points you made about how to combat and deal with transgenerational abuse, and also how important it is to also include non-medical persons like those in banking and in the legal sector about older persons and protection of that population and how they could be involved. So thank you very much. We appreciate you presenting to us today.
Thank you for having me. Thank you.
You're welcome. Okay, so as we move along in session 4, for Research Day, our next presenter is Dr. Keishan Wilkinson. She is a recent graduate of the DM program in family medicine, and she is employed at Princess Margaret Hospital. She's coming to share with us her research on the prevalence of anxiety and post-traumatic stress disorder and associated factors amongst adults in New Providence during the COVID-19 pandemic. Welcome, Dr. Wilkinson.
Good evening, everyone. Just want to share my screen. Just give me a second. Okay, thank you guys for your patience. Okay, good evening all, and thank you for this opportunity to present my research on the prevalence of anxiety and post-traumatic stress disorder and associated factors among adults in New Providence, the Bahamas during the COVID-19 pandemic. According to the WHO, mental health is more than the absence of mental disorders. It is an integral and essential part of health. As we have seen, recurrent infectious diseases continue to overwhelm the mental health of populations globally. COVID-19 has caused millions of infections, burdening public health, especially in developing nations like the Bahamas. The literature revealed that in Wuhan, where COVID-19 first emerged, 44.5% of participants had symptoms of PTSD. In the Caribbean, Jamaica noted nearly 100% of participants reported significant impacts from COVID-19. One may ask, why is this study so important? The current evidence suggested that a psychiatric epidemic was co-occurring with the COVID-19 pandemic, as the psychological dimensions of the pandemic was yet to be understood. Unlike our Caribbean counterparts, to date there are no published data available in the Bahamas, and therefore it was important for us to carry out a similar study in our country. I had hypothesized a mostly female population with an expected mental health prevalence of 40 to 60% and an anticipated non-response rate of approximately 15%. The study's aim was to assess the prevalence and associated factors of anxiety and PTSD among adults residing in New Providence, the Bahamas during the COVID-19 pandemic. The objectives of this study were to determine the prevalence of mental health diagnoses among the population, as well as determine the factors that are associated with these diagnoses and describe the medical socio-demographic profile of participants. The study took place in the capital of the Bahamas, specifically at 3 highly populated outpatient government clinics, and was a cross-sectional study design conducted during October 2022 to February 2024. The study comprised of adults dwelling in the communities that sought care at these clinics, and convenient sampling was employed for participant selection. Participants included were 18 years and older who provided consent and attended the selected government clinics, whilst excluding those not meeting this criteria. The study aimed for a minimum of 434 potential participants, and the data collection instrument was a self-reported questionnaire comprising of 3 sections. The third component had 2 subsections that used free validated self-reported scales. Total scores across the 7 items, when calculated, classified anxiety symptoms as normal, mild, moderate, and severe. And for the PCL-5, a cutoff of greater than or equal to 31 points was used to determine probable PTSD. Pre-testing was done and minor adjustments made, and potential participants were approached conveniently by the research team during the 5-day work week. Information was collected, double entered into current version of Microsoft Excel, clean, saved, duplicated, and stored on a password-protected computer. The prepared data was exported to the latest locally available version of SPSS. Descriptive and inferential statistics were calculated. Additionally, the prevalence of anxiety and PTSD was identified. Statistically significant relationships were determined. All respondents were kept anonymous throughout the study. Ethics approval was received, and the study was deemed low risk due to the non-sensitive nature of its questions. Respondents were provided with the Bahamas Psychological Association helpline and referred for psychological support if needed. Of the 360 participants invited, 287 completed the survey, giving a response rate of 79.7%. Participants were mostly female, Bahamian, Black, and with an average age of 43.9 years. Participants were 49.8% were never married, approximately 88.5% lived with others. Majority were Christian, and 43.5% completed senior high school as highest level of education. Nearly half reported working full-time, and a little over a quarter had yearly income that fell between $10,000 to $20,000 or $21,000 to $30,000 Bahamian dollars. Regarding pre-existing mental conditions before March 2020, 13 out of the 287 respondents had anxiety, with 3 of them diagnosed before the pandemic. Participants reported excellent or good physical, mental, and emotional health. And the prevalence of GAD was 24.7%, of which 16.4% reported mild anxiety levels. A linear trend was noted in the chi-square test linear by linear association, indicating that lower income levels corresponded with higher anxiety levels. Moderate and severe GAD anxiety levels were prevalent among participants with pre-existing anxiety. This relationship was shown to be statistically significant. As it concerns participants' health status, mild anxiety levels were among those with overall good health, while fair or poor mental health correlated with moderate and severe general anxiety levels. And this relationship was also found to be statistically significant. GAD categories are found to be statistically significant among participants whose perception of COVID was highly infectious, were quarantined due to COVID exposure, and those participants who spent an average of 4 to 6 hours online. Additionally, statistical differences were found for participants who contracted COVID, whose household members contracted COVID, as well as those extremely worried about a family or friend becoming infected with COVID. The prevalence of symptoms suggestive of provisional PTSD based on DSM-5 criteria was 4.2%. Significant age differences were found between those with and without PTSD based on symptom severity as revealed by One-Way and Novo. Similar to GAD, the presence of PTSD was found to be statistically significant with reported pre-existing anxiety. Furthermore, responses for mental and emotional health status were found to have statistically significant differences in participants with and without reported provisional PTSD based on DSM-5 criteria. This statistical significance was also seen for PTSD total scores, with the only addition being physical health status. Significant associations were found between probable PTSD and participants whose household members got COVID using PCL-5 symptom severity. In our research, we observed a notable yet relatively low occurrence of GAD and provisional PTSD among the study participants. Furthermore, the variables listed here emerge as statistically significant factors associated both with GAD and PTSD. Subsequently, we pinpointed high-risk groups. Our research revealed that pandemics present as a risk of the mental health of the vulnerable populations mentioned earlier. This assertion is reinforced by an extensive literature review demonstrating the adverse psychological effects associated with COVID-19. The study's prevalence of anxiety, although consistent with that of international studies, reported a lower occurrence of moderate to severe anxiety levels compared to the international studies. Additionally, in our study, participants were less likely to report anxiety compared to a similar study done in Jamaica. Similarly to Kademi et al., our study indicated lower rates of provisional PTSD diagnosis compared to past research by Chen et al. These differences in the prevalence of GAD and provisional PTSD may stem from variations in sampling methods, assessment tools, severity rating criteria, and data collection timelines. Our study's findings were similar to Rodriguez-Ray et al., where individuals with lower income showed higher psychological impact compared to those earning more. Higher income earners may have had better access to healthcare, therapy, and social support, which can buffer against the psychological impact of a pandemic. Our results align with prior studies showing that adults with pre-existing anxiety disorders are more likely to experience heightened anxiety symptoms and PTSD-like reactions amid the COVID-19 pandemic. Individuals with mental health conditions may experience a change in their sense of personal control and self-efficacy during pandemics, potentially hindering their ability to cope with pandemic-related stress. Lower perceived overall health emerged as a significant correlate of heightened generalized anxiety disorder, as well as PTSD during the COVID-19 pandemic, and this was supported by several articles. Physical, mental, and emotional health challenges can exacerbate feelings of vulnerability and decrease resilience, leading to increased anxiety and PTSD symptoms. Elevated mental health symptoms were observed among individuals with personal COVID infection or an infected relative or friend. This was consistent with research that linked adverse outcomes among loved ones during disasters to mental health issues. And this could be due to the direct impact of infection, as well as the emotional impact of loved one's infection, disruption of the social support network by social distancing measures, and a myriad of COVID-related stresses. Those subjected to quarantine experience heightened levels of psychological distress, including generalized anxiety disorder and provisional PTSD. Isolation during quarantine can lead to frustration, boredom, difficulty accessing supplies, disrupted information flow, increased fear, and ultimately anxiety and PTSD. Individuals spending prolonged hours online exhibited heightened levels of anxiety and provisional PTSD compared to those with limited online exposure. This extended online presence correlates with increased access to COVID-19 information, including misinformation, intensifying apprehension, and augmenting the psychological toll of the pandemic. The study design itself may have been a limitation. Unlike longitudinal studies, there was no differentiation in timelines, which would have been ideal since the pandemic occurred in 3 waves. Another limitation was limited access to patients at the clinics. And finally, the stigma towards mental health in the Bahamas may have also contributed to the unwillingness of potential participants, leading to an underestimation of GAD and PTSD prevalence. This is the first local study done on the general population. As such, it may have sensitized the population to the importance of mental health, thereby decreasing the overall stigma, as well as the impact of natural crises like pandemics on the mental health of the community. In light of these findings, we present recommendations aimed to mitigate the psychological impact in the Bahamas and promote mental well-being in the community. Family physicians in the Bahamas play a vital role in addressing GAD and provisional PTSD by providing holistic care and support to affected individuals. In light of the identified prevalence of GAD and provisional PTSD among vulnerable populations in the Bahamas, the establishment of integrated behavioral health systems in primary care involving collaborations between family medicine and psychiatric specialists is imperative. In addition to the efforts of the Ministry of Health and Wellness, the government of Bahamas should prioritize the implementation and improvement of mental health intervention policies to ensure comprehensive and accessible care for individuals with mental health conditions. Future research, particularly longitudinal and qualitative studies, is pivotal in advancing our understanding of the mental health stigma, as well as the prevalence of GAD and PTSD in the Bahamas and their COVID-19 pandemic impact. So in conclusion, mild anxiety and little to no PTSD were prevalent among the general population during the COVID-19 pandemic, and one can conclude that feelings of anxiety and symptoms of PTSD are a normal reaction of the human psyche in the face of a global threat. Insights from international, regional, and local studies, including this one, contribute to laying the groundwork for effective responses to natural disasters, such as the coronavirus pandemic. These are my references. I would like to acknowledge the following persons who assist me in developing this research project. Thank you for listening. I will now welcome any questions.
Thank you, Dr. Wilkinson. Do we have any questions? So, Dr. Wilkinson, why did you decide to study both general anxiety and PTSD? Why did you do a study combining findings for both?
Firstly, working during the COVID-19 pandemic in the community clinics first at Agape, we were seeing a lot of patients who came in and met criteria for both anxiety and PTSD. And when I did my research on the actual tools, based on your cutoff point for GAD, you could also diagnose PTSD. So I wanted to see if there was any difference in that it was such a major impact, psychological impact based on what we were seeing in the clinics. I just wanted to see if we would have seen that in our community by doing research.
Okay, great. Thank you so much for your presentation. Very insightful data, and your analysis is very interesting on those areas, and we look forward to any future work that may come out of it.
Thank you.
So we move on to our next speaker, who is Dr. Andrea Culmer. She is also a family medicine resident, actually a recent graduate of the DM program of family medicine at Princess Margaret Hospital. And we welcome her now as she presents her research on adolescents, help-seeking intentions, and mental health literacy of depression and anxiety in Eleuthera, the Bahamas. Dr. Culmer.
Good evening. I'm Dr. Culmer, and I appreciate this opportunity to share my research on adolescents' health-seeking intentions and mental health literacy of depression and anxiety in Eleuthera, the Bahamas. Mental health literacy is defined by Jarman al. as knowledge and beliefs about mental health problems, which aid in their recognition, management, and/or prevention. Mental health affects one's overall well-being. Approximately 50% of mental disorders emerge by the age of 14, with depression and anxiety accounting for almost half of these. Catastrophic events lead to an increase in the prevalence of mental disorders, and we in the Bahamas have had our fair share of two major consecutive catastrophic events, namely Hurricane Dorian and COVID-19 pandemic. The rationale is that studies related to mental health literacy and health-seeking intentions are lacking in the Bahamas, certainly in the adolescent population, and residents of family islands have limited access to mental health care. The aim of this study was to assess the health-seeking intentions and mental health literacy of depression and anxiety in adolescent students in Eleuthera, the Bahamas. The objectives were to assess adolescents' mental health literacy regarding depression and regarding anxiety, to assess adolescents' health-seeking intentions for mental illnesses, and to identify any variations of mental health literacy based on sex. The methodology follows, with the study being in the Bahamas, which is a chain of islands. New Providence and Grand Bahama account for the most densely populated islands, and the study took place in Eleuthera, which is less populated. The study was a cross-sectional quantitative study over a 1-year period, and single-stage cluster sampling was used. Adolescents enrolled in and attending one of the 3 northern public high schools on Eleuthera in grades 8 to 10 during the academic year of 2023 to 2024 were approached. These schools include the North Eleuthera High School in Lower Bourg, Eleuthera, Samuel Guy Pinder All-Age School in Spanish Wells, and the Harbour Island All-Age School in Harbour Island. Inclusion criteria were that students must have been enrolled in one of the 3 mentioned schools in grades 8, 9, or 10, able to communicate properly in English, and have given consent and assent. Exclusion criteria were those without consent from parents or guardians, students with learning disabilities, and students who had previously diagnosed mental illnesses. After accounting for a finite population and an estimated non-response rate of 15%, the minimum sample size was estimated at 173. The data collection instrument is a questionnaire that was adapted from the Friend in Need questionnaire and the Australian Mental Health Literacy Youth Survey. This consisted of 48 items, collecting information on socio-demographics and participants' health practices. It also had 4 vignettes, one on social anxiety disorder, one with depression, with suicidal ideations, and one without suicidal ideations under control. And each was followed by mental health related questions. It also collected information on participants' available support and their understanding of mental illnesses. The primary outcome of the study was mental health literacy, with adequate mental health literacy receiving a score of 3, with 1 point being given for the correct recognition of the disorder, 1 for an appropriate level of concern, and 1 for suggesting help seeking. Data that was collected was entered using the REDCap survey instrument. It was then exported into State of Standard Edition software version 16.1. Errors were removed and data was cleaned for further analysis. Files were stored electronically and backed up, and hard copies are also physically secured, with confidentiality being maintained. Data analysis was performed using descriptive and inferential statistics, with descriptive statistics summarizing central tendencies and dispersions used for continuous variables like age, and percentages for categorical variables like grade, sex, and race. Inferential statistics used 95% confidence intervals, and hypothesis testing was done to examine relationships between the variables, specifically the magnitude of association with respect to sex. And regression analysis was performed to model the probability of participants' help-seeking suggestions. Ethical approval was granted by the relevant parties. Permission to conduct the research was given by the Ministry of Education and the local participating schools. Informed consent and youth assent were obtained, and the study was of minimal risk, with confidentiality being maintained. The results are as follows. The response rate was 56.6%, noting there was an expected sample size of 173, however, there were 98 participants. 56.1% were female, 43.9% male. Majority attended a Northern Lutheran high school, and majority identified as being of the Black or Afro-Caribbean race, with a median age of 14 and interquartile range of 12 to 16. Noted that 1 point was given for correct recognition of the disorder. 91.8% of participants identified anxiety. 77.6% identified depression without suicidal ideations, and 72.4% identified depression with suicidal ideations. Notably, for depression with suicidal ideations, there was a sex association which was statistically significant, with females identifying this more than males. 1 point was given for an appropriate level of concern, and an appropriate level of concern was participants identifying as being quite worried or extremely worried for the character in the vignettes. For anxiety, this was 59.2%. For depression without suicidal ideations, it was 71.4%. And for depression with suicidal ideations, it was 68.4%. And again, 1 point was given for those who recommended help seeking. For anxiety, this was 80.6%. Depression without suicidal ideations was 76.7%. And for depression with suicidal ideations, it was 72.4%. A therapist or counselor was recommended approximately 30% of the time across the vignettes. This was then followed by family and friends who are informal sources. And here I highlight the formal sources, which include the mental health professional and the doctor or nurse, which were very rarely recommended as sources of help. Mental health literacy was then calculated, and it was found that for anxiety, this was 48%, and for depression, it was 44.9%. And using the table below, it was categorized as having a fair mental health literacy. Binary logistic regression was used to determine the likelihood of participants suggesting help seeking, and this was with respect to disorder recognition, the level of worry, and estimated recovery time. For social anxiety disorder, those who were extremely worried versus not worried at all were 2.24 times more likely to suggest help seeking for anxiety. For depression without suicidal ideations, there were no individual significant predictive factors. However, for depression with suicidal ideations, those participants who estimated that it would require 2 months or more to recover from depression versus 1 or 2 days were 1.75 times more likely to suggest help seeking. What does this all mean? A fair level of mental health literacy for anxiety and depression. That's approximately 1 in 2 adolescents in Eleuthero. Females had a higher rate of mental health literacy for depression without suicidal ideations than males. They recognized depression with suicidal ideations more than males. And females had a higher degree of concern for depression overall, which was similar to findings by Burns and Rapey and Coles et al. And this is likely due to females being more open to communicate about their emotions, seeking emotional support, and society encouraging females more than males to express their thoughts or feelings, which leads to a self-awareness and understanding of mental issues amongst females more. With respect to help-seeking intentions, for anxiety, these participants had high awareness, which was associated with strong help-seeking intentions, and depression, there was moderate awareness associated with moderate help-seeking intentions. However, there was no difference, no association with respect to sex. The therapist or counselor was suggested mostly by participants, and this is likely due to their sensitization via online communities, as all participants mentioned having access to the internet. Notably, participants hardly recommended a mental health professional or a doctor or a nurse. And this is likely due to limited awareness of support, stigma and fear of judgment, limited access to care, and the preference for informal sources. Strengths of the study included being the first of its kind on a family island in the Bahamas. It focuses on a group particularly susceptible to mental health challenges who are often overlooked in research. The multifaceted approach to obtaining the views of adolescents and their behaviors and awareness of mental health, and it captures a general view of adolescents in Eleuthero. The limitations included having a lower than expected level of participation, response bias due to participants not wanting to disclose certain information. Private school attendees were absent from this cohort, and it's not generalizable to all adolescents of the Bahamas. Recommendations to improve mental health literacy include on a family level or individual level, conducting further research to explore stigma surrounding mental health literacy, as the family unit is where values are instilled and will influence our adolescents. At the community level, implementing programs that promote peer support and providing safe spaces for help seeking can aid with improving mental health literacy. At the educational level, increasing the availability and the visibility of school guidance counselors is important, and also incorporating mental health literacy programs into the curriculum. And at the healthcare level, we in the healthcare system can share our resources, and we, especially in the family medicine community, can be supportive for our families. And of course, screening at the appropriate recommended times by the recommended by the United States Preventative Services Task Force. Further studies include expanding research across the island of Eleuthero, other family islands, and also comparing findings in New Providence and Grand Bahama, and ultimately extending this across the region. It would be beneficial to incorporate qualitative methods in order to gain deeper insights and use school-based meetings or videos to improve engagement and response rates. In conclusion, the study is the first of its kind in the Bahamian Family Islands. It highlights the need for improved mental health literacy in adolescents. It highlights the need for access to care among adolescents, and interventions targeting mental health literacy are crucial. These are my acknowledgements, references, and I thank you for your attention.
Thank you, Dr. Kulnar, for this presentation, a very pioneering work in Eleuthero. So thank you for doing that. Do we have questions for Dr. Kulnar? So Dr. Kulnar, did you run into any challenges with recruitment of persons to participate in your study, particularly gaining consent or assent?
I certainly did. Getting the consent in a timely manner for the timeline that I was working with was a challenge. I found that one school in particular was not receptive to it. I know that administration said that they were trying, but they were getting a lot of resistance.
Okay, thank you. Is that related to any stigma around mental health, do you think?
It's possible. And also in our family islands, we have our communities create like micro ecosystems. So in that particular community, for the feedback that I got was that the students didn't want to take it home, period. So they were not even open to the idea of taking the consent letters home to their parents. So I don't understand that dynamic, but it's something that I'm willing to work through in future studies moving forward.
Thank you. Very interesting. All right. So we thank Dr. Comer for our presentation.
Sorry, can I ask a question real quick?
Sure.
Yes, Dr. Comer, thank you for your presentation. Just going along with Dr. Grimes, you said there appeared to be more resistance from the students to take it home to their parents. When you actually interacted with, when the request was actually made of the parents, was there any difference? Were the parents more willing, or did you find the same level of resistance to that, or was there some discordance between the child's apprehension versus what you saw with the parents?
Well, the issue was ideally I would have preferred to have had a virtual meeting with the parents, but that didn't happen. So I only sent letters. So the mode of communication, I think, could be improved on in order to get that increased response rate. Because I don't think there was a clear understanding, even though, the letter would describe what is happening, because it's not like I was doing any diagnostic testing. It was just basically a knowledge-based survey. So I don't think there was complete understanding as to what was being requested.
Okay, thank you.
Thank you, Dr. Comer.
Thank you.
So we will roll right along. You're welcome. We'll roll right along in our program, and we thank everyone for remaining with us as we proceed in session 4. Our next presenter has a pre-recorded presentation. Dr. Sharinda Dean is a recent graduate of the Family Medicine DM program at the Princess Margaret Hospital. Her presentation will be on knowledge, attitudes, and prevalence of intimate partner violence among tertiary students in New Providence, the Bahamas.
Good day. I'm Dr. Sharinda Dean, Family Medicine postgraduate, and today I'll present my research on the prevalence, knowledge, and attitudes regarding intimate partner violence among tertiary students in New Providence, the Bahamas. This is my outline. Intimate partner violence is a global issue experienced around the world, irrespective of race, class, or socioeconomic status. It is defined by the World Health Organization as any act of violence, whether physical, emotional, or sexual abuse, and may involve coercive or controlling behavior between spouses, boyfriend, girlfriend, or ongoing sexual partners. According to the CDC, it is a growing health gender roles, which encourages male perpetration and female victimization. Therefore, gender socialization justifies and perpetuates such violent behavior. Often making the headlines, we see that domestic violence is sadly on an upward trend. One instance took place January 2022 in the Bahamas, in which a young aspiring photographer was slain at the hand of her newborn's father, who then in turn ended his own life. In review of the current literature, the CDC notes a number of overlapping risk factors, including poor self-esteem, childhood experiences, or mental health disorders. A study in South Africa by Makubele et al. Showed that IPV affected students' confidence and ability to achieve personal goals, while cultural values skewed how school counselors dealt with affected students. Yagiz et al. Performed a cross-sectional study on nursing students in Turkey, whereby male students were found to be more likely to have violent tendencies and accept domestic violence. A few studies were done throughout the Caribbean. In Jamaica, Gibson et al. In 2000 revealed that 50% of patients hospitalized for trauma were at the hands of a violent partner. This therefore also placed the female victim at increased risk for contracting HIV. In the Bahamas, Bethel et al. Surveyed over 600 students at the University of the Bahamas in 2019. Nearly 30% admitted a history of being sexually assaulted. All female students reported the assault to an official, while none of the males reported the act. Further studies show that victims may experience depression, exhibit high-risk sexual behaviors, or fall victim to homicide. And barriers seeking help are often resulting from lack of awareness of available services, physical disability, or simply fear. The rationale of this study is because of the deficit in research on IPV among college students, especially throughout the Bahamas and Caribbean. Therefore, as gatekeepers in healthcare, it is important that primary care physicians assist this vulnerable population to improve their knowledge, coping skills, and ability to access resources. It was hypothesized that 30% of tertiary students had a history of experiencing IPV. 50% would have a good level of knowledge, while 30% would have poor attitudes regarding IPV. The aim of this study was to assess the prevalence, knowledge, and attitudes of intimate partner violence among tertiary students in New Providence, the Bahamas. The objectives were to determine prevalence, level of knowledge, and attitude among students, and how the socio-demographic profile of respondents correlates to an increased risk of experiencing IPV. A cross-sectional study was performed from January to April 2023 using a convenience sampling approach. 3 tertiary schools were selected as willing participants from the list of registrants with the National Accreditation and Equivalency Council. All available students were approached and asked to participate. Students were asked to participate once they were adult Bahamian tertiary students fluent in English after giving consent. Persons not meeting this criteria were excluded. Cochrane's formula was used to determine the minimum sample size using a 95% confidence interval and 5% margin of error, for a minimum sample size of 369 with consideration for the expected 10% refusal rate. Ethics approval was given by the relevant authorities and permission obtained. Informed consent was obtained from all participants and privacy maintained throughout. The phone number for the community counseling and assessment physician was provided for all participants. A 32-item self-administered online questionnaire adapted from Umana et al. Was modified to suit the population of interest. Knowledge and attitude scores were determined by establishing a cutoff greater than 50%, which indicated a good score. Completed questionnaires were double entered into an Excel spreadsheet and cleaned of errors. Quantitative analyses were performed. Statistical analysis was done for descriptive statistics, inclusive of measures of central tendency and dispersion, and inferential statistics with a 95% confidence interval. This study was considered to be of moderate risk. Now let us take a look at our results. 647 students were noted to view the online survey, and 233 completed the study. There was a 36% response rate. The majority of study participants were female, 55% between 18 to 20 years, 93% were Christians, whilst the 95% were single and less than 1% either divorced or widowed. Nearly 90% were heterosexual, and more than 50% of students were unemployed, while 70% had a household income of less than $30,000. 96% of participants were undergraduates, with 87% attending the University of the Bahamas. The majority of students who participated were nursing students with a total of 55 or 24%. In this study, it was found that 30% of students experienced some form of partner violence. 63% correctly defined IPV, selecting all of the above option. 88% of students had good knowledge. 83% of males and 90% of female students had good knowledge. However, no statistically significant differences were noted regarding sex or age group, by marital status, or sexual orientation. Although there was a statistically significant association with students' level of knowledge regarding IPV based on level of education, the number of postgraduate and doctorate student respondents was minimal as compared to undergraduates and therefore not reliable. There also was no statistically significant differences with students' level of knowledge regarding IPV based on annual income. As related to attitude, 72% of students had good attitude. There was a statistically significant difference between male and female students based on their attitude towards IPV. However, no difference was found based on age, marital status, sexual orientation, level of education, neither based on participants' annual household income. When asked about participants' attitude regarding good reasons to beat a partner, the mode response was no. However, a small proportion of participants did indicate that they did not know. This was the response for as many as 8% of students regarding infidelity or maltreatment. When asked which situations will trigger a perpetrator to be violent, majority indicated there was either no particular reason or a result of jealousy. Moreover, the most prevalent injuries reported were scratches, abrasions, or bruises, with least common being burns, broken eardrums, or eye injuries. In response to reasons for seeking help, 30% were encouraged to do so by friends and family. 35% of respondents stated they did not go for help. 11.5% went to a police officer, while none went to either community leader or shelter. 7.7% could no longer endure the abuse. 2% never left, and none indicated being badly injured. 11 or 4.7% of total participants stayed with their partner because they forgave them. 7 or 3% stayed out of fear of what would happen to their children, and 1 thought that violence was normal and not serious. There was a statistically significant relationship between alcohol use and experience of psychological violence. The majority of participants were single, Christian, heterosexual females between 18 to 20 years of age, with 90% being undergraduates. This was similar to the profile of respondents studied by Umana et al., whom also had a prevalence of psychological abuse. This may be due to the current era, as phenomena like cyberbullying, emotional and psychological aggression are more apparent than previous years. And O'Keefe et al. Documented that students with close friends who experienced dating violence also did so themselves. We also found there was no statistical difference in prevalence between female or male students, likely due to underreporting by their male counterparts, as males most often internalize their feelings. Alcohol use was noted to increase the risk of psychological abuse by 15%. Dardis et al. Also showed that alcohol use increased the risk of all types of IPV due to impaired judgment and ability to communicate. 2/3 of students in our study correctly defined IPV. Jiao et al. Compared students throughout Asia as those who disapproved of absolute male dominance were most accurate in detecting abuse. It was hypothesized that 30% of students would have demonstrated poor attitudes, which was relatively consistent with our findings. Female students were more likely to demonstrate good attitude compared to males. Fielding et al. Performed a study on learned behavior within the Bahamas, which demonstrated that despite societal influences, the more educated an individual is, the less likely they are to support the idea of the universal submissive female servant. Over 1/3 of students in our study did not seek help, likely due to deeming violent behavior as a symbol of love or not being serious. Umana et al. Reported students were often fearful of others' opinion or blame themselves, while Iniqua et al. Showed promise in students reporting the act, however, to a family member instead of an official authority figure. Limitations of this study included social stigma, as some individuals may not have been truthful in their responses. Therefore, questionnaires were completed in privacy and anonymously. Furthermore, low response rate may have been due to difficulty in accessing participants, which may have affected data collection and ability to achieve minimum sample size. The prevention of IPV requires a collaborative effort. Therefore, the following recommendations may be considered. Gender socialization should be restructured within the family and discourage individuals suffering in silence. The Ministry of Education should be admonished to establish courses that aid students in critical thinking and conflict resolution, as demonstrated by Jiao et al., to increase students' awareness and reporting to officials. Moreover, the family physician is well poised to aid victim empowerment while identifying perpetrators and referring them for comprehensive behavioral therapy, which also supports the need for future studies. In conclusion, IPV was quite prevalent among our students. The majority had good knowledge and attitude. However, psychological abuse was most prevalent, especially when combined with alcohol use. Therefore, more education is still needed within the community and individual families to decrease potential gaps and provide support. I would like to thank my supervisors. These are my previously mentioned references. I thank you for your time.
We thank Dr. Dean for her presentation, a very interesting presentation. Is Dr. Dean on the call with us to answer questions?
Good evening. Yes, I am.
Good evening. Thank you. So there is a question in the chat. Dr. LaVille, would you like to unmute to ask your question? The question
Hi, sorry
is
about
what
that.
was,
I was referring to the prior presenter about the anxiety and depression in Eleuthera. I was wondering what the prevalence was before the pandemic, if they had anything to compare with in Eleuthera.
Okay, so Dr. Kulma could possibly answer that in the chat for you, Dr. LaVille. Any questions for Dr. Dean at this time? Dr. Dean, I have a question. Can you comment on the reasons for the non-response rate to your survey?
When asked, some students refused to accept the link or just simply stated they've never been in a relationship or didn't have experience with partner violence, so they didn't know how to answer the question. Or they just weren't interested in the topic. So I attribute that to an increase in participants not participating or just viewing this survey and not actually completing it.
Okay, thank you very much for that response. If there are no other questions for Dr. Dean, we will proceed to our next presenter on the program. With us is Dr. Patrick Anglin. He's a graduate of the University of Manchester with Manchester Business School, where he pursued a Doctor of Business Administration. He received a Master's in Business Administration from the Mona Business School at the University of West Indies in 2000, and Bachelor of Science in Computer Studies, also from UWI in 1996. Dr. Anglin's research interests include the impact of information and communication technologies on productivity, the use of ICT in small and medium enterprises, knowledge and management, agro-tourism, agribusiness, and ICT benchmarking. Dr. Anglin drafts ICT policy and works on enterprise-wide ICT projects spanning the UWI's 4 campuses and 15 country locations. In addition to owning his own consulting firm, he is also an associate lecturer at the UWI Consultancy Company. He currently sits on the Distance Education Standards Committee at the University Council of Jamaica and on the Technical Working Group of the Jamaica Research and Education Network. Dr. Anglin, as a member of the UWI's AI subcommittee, looks closely at the data protection issues that will arise and have arisen due to the ever-increasing use and dependence on AI tools. He's currently a data protection officer at the University of West Indies, Mona, and he will be presenting to us the topic, Balancing Patient Privacy and Data-Driven Research Objectives. Welcome, Dr. Anglin.
Thank you. Thank you very much. I'm Dr. Grimes, and thank you for the invitation to be at your Research Days 2024. I hope you can hear me clearly and you can see my presentation.
Yes, we can to both.
Lovely. So I am not sure why I would have been placed in the mental health section. I'm not sure if that's a message to me, but I am happy to join you under the theme Innovations in Healthcare, Empowering Lives, Advancing Medicine. And my own presentation is really about that balance that we must make, that synergy that we must achieve between innovation and ethics, especially in respect of research. I'm going to be covering a couple of things, well, 5 things actually. By way of introduction, I'm going to be explaining to you what we do in my office. And I'm going to quickly run through the importance of data-driven research. And I'm sure you know this already because I'm hearing some of the presentations and they're really, really good. I'm going to go through the challenges in respect of patient privacy, but not only patient, but really the researched privacy. And what are some strategies for protecting privacy? And then I'm going to introduce a framework to achieve the balance. And if we have time, we go into Q&A. So by way of introduction, I am at the moment heading the university's data protection practice. Our practice, it's not specific to Mona. It spans the entire 26 jurisdictions across which the university operates. 17 of these are in the Caribbean and 9 are outside. So what we do, we ensure, or at least try to ensure that privacy is at the forefront of the minds of both staff members, whether they be academic or non-academic, as well as students. I'm not going to get into the details of privacy in this particular session, but by way of working definition, I just want to anchor on data-driven research. And I want us to recognize that data-driven research refers to those methods or methodologies that rely on data collection, analysis, and storage to derive insights. And some of these collections may be extensive. And I have been hearing quite a bit about data collection since the session. I've been sitting here for about 2 hours listening to the wonderful presentations. The purpose of my presentation is really to explore how data-driven research can be balanced with protecting, and I say patient privacy because I know that we're focused on the medical side. But it's not just about the patient, it's about the research subject and ensuring that the research practices are ethical and societal benefits are maximized. Now, the Data Protection Office at the University of the West Indies, we look across all operations of the university. And as you can probably understand, a university has a multiplicity of functional areas, be they medical, be they engineering, be they accounting, be they information technology, or any other endeavor. But what you're going to find is that the privacy considerations tend to be the same. So while I am customizing my presentation for the research space, many of the principles transcend research. But let me remind you about the importance of data-driven research. So when we gather data, we use the insights obtained to revolutionize what we do. And in this particular case, we're talking about healthcare. We're talking about discovering new insights in terms of treatments and ensuring that we improve patient outcomes. And also, these days, getting more personal in respect of medicine. But on a broader level, we still want to understand the community health, understanding disease patterns, understanding how we utilize the institutions of healthcare, and whether the outcomes that we expect to get, we're really getting them. So that is the importance of getting our own data, especially in this part of the world. So where does innovation and technology come in? Well, technology supports the development of the space, the knowledge, and some of it is artificial. We do have artificial intelligence and machine learning, and one of our presenters spoke about that earlier. And these can be used to predict health risks. They can be used to predict treatment responses. But one of the questions we need to ask ourselves is, what is the impact of what we're doing? One of the quandaries which have been facing us as a privacy community is, to what extent do we allow these machines to learn about private components of the human and use that to generate the responses? And that is a dilemma that we're facing. Now, this can cause us to get better designed clinical trials. It can cause us to write better policies. And it, again, can get more personalized in terms of better patient-centric care. So we recognize the benefit of data in our research. But there are some challenges. There are challenges in respect of subject privacy, and it's quite complex. But what are we talking about? Well, on a broader level, when we speak about the subject, we speak about the individual whose information can be used to identify them. That is the data subject. From a health perspective, patient privacy really is about the health information. But more generally, any information that can be used to identify an individual is really personal data, and that is what we want to protect. But there is a balance to be achieved: privacy versus utility. There is a recognition that good research, high quality research, requires granular information, granular data. And there are some instances where this might compromise the anonymity of the patient. Remember, personal information or personal data is anything that can be used to identify the individual. And that is what we're trying to protect. So when we present our research findings, we try to ensure that we de-identify the research subjects. But most importantly, how we manage the data before we present it is important. More challenges. Even if we get good consent and we try our best to keep data private, we recognize that there are some malicious actors out there. Data breaches and some cybersecurity risks are ever present, and especially when we're talking about large data sets. These large data sets are attractive to our malicious actors. And therefore, we must put in place robust security measures. So it's not just about data collection, but it's also about data storage and management. I heard earlier about persons not consenting or not responding to the questionnaires. And there is a difficulty at times, and I've met this in my own practice in respect of persons understanding what they're consenting to. we must ensure, researchers must ensure that the subject fully understands what they're consenting to, one, but also the extent to which the data that is collected about them will be used in the research. Oftentimes, I have noted that consent mechanisms do not go far enough in indicating to the research subject or subjects how the information or data collected is going to be used. Also important is that of anonymization. While techniques are sometimes implemented to anonymize data, these themselves don't go far enough. We try to ensure that we remove personal identifiers, but there are sometimes things about a population of study, which by the very nature of the population leads to their identification. It gets more complicated. Since 2016, the European Union launched its General Data Protection Regulation. It gave the rest of the world 2 years, including the Union itself, to become acclimatized before it came into full effect. That has complicated matters for those of us whose subjects are resident in Europe. HIPAA out of the US is also another complication to the research process in terms of gathering information. But also, in addition to HIPAA and GDPR, of the 193 countries in the UN system, roughly 160 of them have come up with a mechanism or some mechanisms to protect the privacy of their residents in terms of data protection laws, privacy laws, regulations, and practice guidelines. So we do recognize that the world has changed. So it's not just about the organization, the university, the hospital putting in place their policies, but all of these must be in line with the legal frameworks which exist globally. And why is this important? It is important because we recognize the benefits of data-driven research, which I highlighted before. And we can lose these benefits if we go far in the other too far in the other direction in terms of trying to remove all the identifiers and make the information that we get not practical in terms of research. So what are some effective strategies that we can use to protect privacy while ensuring that we get the benefits of the research? Well, we spoke about anonymization, but it's not just ensuring that we remove the obvious identifiers. There are some identifiers which, when combined, can be used to identify individuals, and we must make sure that we pay attention to these. Oftentimes, though, we want to get rich data. And I'm going to go back to the consent mechanism. Sometimes our consent form is not sufficiently targeted to the data that we need. And the concept of data minimization indicates or says that you should only collect what is necessary for this purpose that is being researched. That is very difficult for a researcher because sometimes you don't know the direction that the research will take. But we have to make sure that the principle of data minimization, as difficult as it is to balance that with collecting rich data, is observed. When the data is collected and stored, there is a risk that malicious actors can break in and steal your information. And therefore, there are techniques that can be used to introduce statistical noise to data sets so that in the event that somebody breaks into your data set, they still can't make sense of it unless it's decoded. But a very simple technique is that of access controls and role-based permissions. This is a very, very simple one to enact. Not everyone who is a part of the organization or even the research team ought to access all of your research data. Access should be restricted based on the role of the individuals. And this one is a very interesting one. It's pretty new. We must start to think about using trusted research environments. And these are secure environments that allow research to continue without exposing the raw data. Too often, I see team members storing large data sets on a personal computer or a laptop. We must start to think about, especially in organizational settings, looking at trusted research environments. Now, these environments are not common in our part of the world. In fact, they're very uncommon. They're largely found in Europe, in North America, Australia. But we do have a few. They might not be called that, but there are a few in the Caribbean. But what are we talking about when we say a trusted research environment? These ensure that what I just spoke about in terms of anonymization, access control, data minimization, all of these things are embodied in an ecosystem. We have a few. So for example, here at the University of the West Indies at our Cave Hill campus, we have CERC, which is the Caribbean Educational Research Center. Now, this trusted research environment already puts in place some of these mechanisms to protect the information that is generated from the data, but also the data itself. CANREC out of CARFA is another one. And we also have another one at our Mona campus, which is the Caribbean Open Institute. Now, these are some of the trusted research environments, and we can talk about that a little more. But I want us to start thinking about the ecosystem around our research data, not just about getting good informed consent, not just about doing good data analysis, but also about the storage, the various security mechanisms, the codification and decodification. All of these things are a part of the trusted research environment. Now, there are some policy measures that we can think about as well. I know that much of what I'm saying you already know. So let's talk about them from a general perspective before we get into the specifics. Protect your research data while it is at rest, meaning on your machine, or while it's being moved between your machine and some other machine, or between a hard copy document and a digital environment. we must try to encrypt our information, even emails. We must also monitor data access. How many persons understand that that chain of custody is important? Because when somebody who is not supposed to have your information gets a hold of it and you don't know, a breach can occur and you are held responsible for that breach. You must ensure an audit trail which monitors data access and thus ensure compliance with the mechanisms which have been put in place across the world. But you must look at the risks as well. Look at the risks associated with the operations of your research. And that is why we try to minimize the amount of data we collect to what is necessary. The more you collect, the higher the risk. At the very outset of your design, your research design, from the point when you're coming up, I'm getting an echo. From the point you're coming up with your proposal, you have to start thinking about privacy. Start thinking about privacy from the moment you start designing your research. Don't just think about privacy at the point when you start to collect data. Think about privacy from your research design perspective. So I've given you a little bit. So let's look at a possible framework to help us come up with the balance. Think about this framework as having 5 components, because we want to ensure that what we do is done in an orderly fashion and it makes sense. So the first component is the governance and compliance component. And these are the policies for the use of data, consent, and sharing. Now, we have very strong ethics components across our various research organizations, very strong. We're not so strong in respect of the different policies which are supposed to be complementing that. So from the organization's perspective, we have to establish clear policies, not only in respect of consent, but also in respect of use and sharing. When the data has been collected and it's stored in the organization, who has access to it? What are the anonymization protocols which ought to exist? That is governance. That's the first component of the framework I want to share with you. The next component is in respect of the stakeholder. These days, many of the countries are saying that we have to produce a privacy statement. That privacy statement would tell the data subject, your research subject, how you're going to be managing their information. So this stakeholder engagement must be a part of the thinking in respect of your research design. Engage your subjects. And this can be a part of your pilot. Engage your collaborators, but also engage the regulators, whether these are internal to your organization or external, but a part of the country's regulatory framework. The third component, which is very strong, ethical review and oversight. Now, try not to quarrel too much with ethics committee when they send back your proposal. Recognize that it is protecting both you and the subject. And these are things, these 3 components are things that the organization must do. But what about you, the researcher? What's your role? put in place the basic safeguards. That's the fourth component of the framework. So if you're going to use a checklist, the first item, governance. The second one, speak to stakeholders. The third one, engage the ethics process very early. And the fourth one is about the technical piece. What tools are you going to be using to de-identify? If you're going to be collecting data the old-fashioned way, using paper and pen, will you be storing your code book alongside your data sheet? If you do that, then the code book becomes compromised if there is a leak. What else do you need to do? And this is the fifth component of the framework. You have to communicate to all stakeholders. And let me go back to the consent mechanism. I have found that many consent mechanisms do not go far enough to indicate to the research subject what they're consenting to. Be transparent, but also be accountable to your stakeholders. So these are the 5 components of the framework. But I'm going to end in the 2 minutes I have with a very, very simple model. And I want us to think about privacy from a different kind of perspective. Think about privacy from the life cycle of the data. So as a researcher, think about your life cycle as having 5 components. You obtain the information, you use it, you store it, you share it, and then you get rid of it. So, data collection. In this part of the life cycle, we're very good at ensuring voluntary and informed consent, but ensure that your consent mechanism goes far in terms of explaining to your subject how the information is going to be used. And if it's going to be repurposed, consent must be given for that as well. Storage, which is the second element, you must ensure that your storage solutions are secure. In terms of data use, try to, as best as you can, anonymize the data. Introduce noise so that if that stored data is breached by a malicious actor, they can't make sense of it. In respect of data sharing, only share aggregated data, and this minimizes privacy risks. And I'd mentioned that there are 5 components. The 5th one is disposal. Ensure that you get rid of the data at the end of its use. So let's look at it pictorially. Collection goes to storage, then use, then sharing, then disposal. So my final thoughts. We recognize that data-driven research is essential for what we're doing now. But implementing strong and robust privacy mechanisms and strategies is crucial. The balance is what we're trying to seek. And it is that balance which will add the most value to what it is we're doing. So those are my 30 minutes, and I'm going to stop there and point you to some useful publications that you may wish to consult if you want to learn some more about what it is we're talking about And if you want to find out how to do it in a more practical way, you can always reach out to the university's Data Protection Office. We're online, we're on social media. Look out for our posts. They're always there for you to ingest. And every year, come February, we have Privacy Awareness Month. Look out for our posts. Those of you who are a part of the university community. If you're not, you can always come to our social media sites, and you can always follow us on Instagram or Twitter. And I'm going to stop there because I know my time is up. And if there are any questions, with your permission, moderator, I'll take them now.
Yes, thank you very much, Dr. Anglin, for this very enlightening, informative presentation. Excellent. Do we have any questions for Dr. Anglin at this time?
Yes, I'd like to pose one. I'm Dr. Mortimer Moxie from Community Health. This relates to the use of data in development of artificial intelligence at this time. Can you comment on that? There is some debate about who should access this data to develop artificial intelligence. Can you give us, the latest update on that situation? Because artificial intelligence is moving ahead, but what's happening to the data that is it is being used to develop this system?
Okay, so the language is the information which is used to train these large language models. So that's really the language. So Dr. Moxie, we have to be careful in terms of what information we allow these models to imbibe, to ingest, to learn from. And that is on us. We have control over what information we allow these things to have. So individually, what can we do? Because the model cannot access your information without you giving it access to it. So let's use a basic example. Let us say that you're using one of these free or paid tools. I'm not going to call any names. In every one of these tools, there are privacy settings that you can engage for it not to use your data. Let me give another example. Let us use LinkedIn, that professional social media network. 2 weeks ago or so, they changed their privacy policy, and LinkedIn started to use your data to train its AI model. They sent out their privacy notice, but many persons did not read it and therefore did not engage the options in the system to say, listen, do not use my data. I want the takeaway to be, Dr. Moxie, that we must start to pay attention to the kinds of data we are allowing all of these systems, social media included, to learn about us. The latest one is X, formerly Twitter. It came out this week that they're going to start selling your personal data to large language model AI systems for them to learn. Go into your X account and check no to that. Pay attention to what is out there. When you store things in the cloud, pay attention to the options which are there. Pay attention. If you learn nothing else, learn these 2 words. Pay attention.
Yep. Thank you.
Thank you, Dr. Anglin. Once again, we thank you for your presentation. I think in your final remarks, it now brings us back to appreciating pen and paper a little bit more in terms of storage of our data and personal information. So we now move along to our next presenter. I just want to first of all announce that due to unforeseen circumstances, Dr. Swan has elected to reschedule this presentation until tomorrow. So our next presenter is also our final presenter for this session, Dr. Devon Roll. She's a recent graduate of the Psychiatry DM program at the Sandilands Rehabilitation Center. He has a pre-recorded presentation on the topic correlations between family structure and socioeconomic status on mental health, on the mental health of mental health clients in the Bahamas. Dr. Roll.
Good day. I'm Dr. Devon Roll. I am presenting on correlations between family structure and socioeconomic status on mental health of mental health clients in the Bahamas. I conducted this research for the completion of my Doctor of Medicine program in psychiatry. I have no financial disclosures or conflicts of interest. So let's talk about some background for this topic. The family unit and environment in which we are nurtured are crucial elements of each person's upbringing and help to shape us into unique individuals. The makeup and stability of the family unit and home environment are correlated with the strength of society. A report by the United Nations Secretary General in 2014 emphasized the importance of research on family concerns, the ramifications of government policy on families, and the support of these policies with programs and subsequent evaluation. The World Health Organization is working to increase the awareness and need for adequate mental health care services worldwide, especially for persons with low and middle income. The initiative has been termed the WHO Mental Health Gap Action Program, or MHGAP. You may have heard of this. This initiative seeks to ensure adequate mental health care for those unable to access treatment. Our literature review included the following: the role of the family. A Taiwanese cohort study by Zhang examined how uncontrollable and controllable adverse life events were related to adolescent life satisfaction and whether family cohesion and self-efficacy mediated the relationship between negative life events and life satisfaction. This study's results showed that perceived family support leads to higher sense of life satisfaction. Zhang also found that family support helped adolescents stand firm against the impact of an adverse life event due to their belief in their competence. Family structure and mental health. A study by Bramlett and Brumberg in 2017 showed that kids in grandparent-only, single mom, and step-parent families had poorer health than kids with two biological parents. This paper found that the disparity in the health of children in non-nuclear families might have been due to lower household income, lack of health insurance, and poor health of caregivers. On the other end of the spectrum, a study conducted in Canada by Wade et al. Found that single parents are at a greater risk of psychiatric disorders than married parents. They found that social support was a protective factor in this population of parents. Socioeconomic status and mental health. Williams and colleagues, in their study of 654 adults from urban Guyana, found that socio-demographic and psychosocial dynamics were more associated with mental well-being than family structure. Females in charge of households experienced more depressive symptoms than women in a nuclear family. Study objectives. 1. To examine the relationship between family makeup and socioeconomic status on mental well-being in mental health clients in the Bahamas. 2. To analyze the impact of mental health on the observed outcomes and identify potential mediators. 3. To compare the results of this study with existing literature to validate or refute previously reported trends. This study is a cross-sectional survey designed by the researcher to gather information from clients being actively managed in the government-sponsored psychiatry healthcare system and for private offices over 5 months. Let's talk about the results. In the socio-demographic characteristics, the study included 243 participants. The percentage of male and female participants was not significantly different, 56.4% and 43.6% respectively. Concerning age, the largest group, 21% of participants were in the 38 to 47 years range, and the smallest was in the less than 18-year range at 9.9%. Of the 243 participants, 179 resided in New Providence, 73.3%. The majority were single at 70.8%, followed by persons who were legally married at 12.8%. A large proportion of participants were Black, 95.9%, and employed, 68.3%. Most respondents answered that they were high school graduates, 54.3%, who grew up in neighborhoods where violence was not as much of a problem, at 50.6%. When looking at family structure, most of the respondents who participated in the study are from non-nuclear family structures. However, the proportions of nuclear versus non-nuclear are similar, with non-nuclear within a plus or minus 10% proportion. When comparing responses as they relate to the male and female heads of the family, it was noted that most participants had their biological mothers, 204, versus fathers, 133, playing a dominant role in their upbringing and upkeep. Also of note, most respondents replied that they rarely or never witnessed violence between guardians. When looking at socioeconomic characteristics, Figure 3 describes the proportion of responses associated with participants' socioeconomic status. From this table, it is noted that the majority of respondents are from lower socioeconomic status at 59.7%, followed by middle at 37% and upper socioeconomic status at 3.3%. Mental health variables. Many participants had a family history of mental health disorders at 94.7%. With regards to substance use disorders, the majority of participants reported cannabis use, 31.3%, followed by alcohol, 25.9%, and nicotine, 20.6%. In regards with mental health disorders, the most significant proportion of respondents was schizophrenia at 37.4%, followed by depression at 21.4%, and anxiety disorders at 14.4%. A large proportion of participants sought the help of a mental health professional after the age of 18, 72.9%. Most participants had a lifetime admission count of 2 to 5 admissions, 31.7%, and had no admissions within the past 12 months, with 72.4%. There were no significant correlations found between family structure and socioeconomic status on the mental health of mental health clients in the Bahamas. Contrary to what was hypothesized, the prevalence of persons in lower socioeconomic status is not greater when compared to middle and upper socioeconomic statuses as relates to mental health severity. However, these results were similar to a study done in the United Kingdom on the increased amount of psychosis among Black and minority ethnic groups, and looked at how lower socioeconomic status may have explained the rise. Their results found that lower socioeconomic status did not explain this rise in the rating of psychosis. This study's participant population included persons actively admitted to hospital and attending mental health clinics. The majority of persons who voluntarily completed surveys were follow-up clinic attendees, As a result of this, the findings may be skewed because clients who have severe mental illness and/or poor family support are less likely to attend clinic follow-up visits and therefore would not be significantly represented in this study. Collecting comprehensive data on family structure and socioeconomic status can be challenging due to the privacy concerns of clients and the sensitive nature of the variables tested. Let's talk about recommendations for the future. 1. Enhance advocacy for the amalgamation of mental health into primary care settings to allow patients better access to mental health care in community clinics close to where they reside. 2. Training for nurses and physicians through the WHO Mental Health Gap Action Program to provide knowledge, skills, and support with regard to the management of the mentally ill in the Family Islands in the Bahamas. And this is something that we are currently doing. 3. Consideration should be given to the establishment of family-focused therapy in the community psychiatric center settings. In conclusion, exploring correlations between family structure and socioeconomic status among mental health clients is a complex but important venture. Understanding these relationships can help identify challenges and discrepancies, apprise policy decisions, and improve mental health care delivery for diverse populations in the Bahamas and the Caribbean. By recognizing the intricate interplay between family structure and socioeconomic status, we can take steps towards ensuring that mental health services are available and beneficial for all individuals, regardless of their family backgrounds and socioeconomic status. Thank you very much for your attention. These are my references.
Thank you, Dr. Roll, for that very interesting, very good presentation. Do we have Dr. Roll on the meeting link with us for questions? All right. I don't think Dr. Roll is with us to take questions at this time. So we thank her once again for providing her presentation on her research. And with that, we will conclude session 4 of Research Day. And we thank you for supporting Research Day sessions today, especially at this late hour. And we look forward to seeing you tomorrow during sessions 5 and 6, beginning at 3 p.m. tomorrow. Thank you all, and good night.
Welcome
hello.
to another Nestle.
Hello, Dr. Grimes. I think that might be 2 p.m.
Okay. Thank you for that
is
correction, Dr. Moxie. Yes.
Yeah, I was
Thank
rambling
you.
to get my mic open.
No
think
problem.
that's what
Thank you very
the
much.
official- let's make sure the official program has, because I'm taking that session tomorrow. Let's see.
Yes, sir.
That's Friday. They have it 2:30. I was told 2, but
Welcome to another Nestle Education Segment Bites for healthcare professionals only. The World Health Organization recommends exclusive breastfeeding during the first 6 months of life and continued breastfeeding for as long as possible. In our quest to provide the best, we have gone a step further, studying breast milk to understand what it delivers for growth and development. This study has birthed our newest option, NAN, with optimized protein, probiotics, and human milk oligosaccharides, while maintaining the proven macro and micronutrients we combined before. As we balance the ingredients of our exclusive combination for reconstitution by your little patients, we ensure even more of the solid components are represented in our infant formula, now including HMOs, specifically 2FL found in 80% of breast milk worldwide and account for 30% of the HMO component. Coupled with the right amount of protein for structural cell and tissue formation, essential neurons and hormones, and general overall body functions, NAN has all that an infant formula currently needs. Even the probiotic blend is superior among infant formulas on the market with our specific selection for the growing infant. Choose NAN with your patients unable to breastfeed for this exclusive combination today. For any further questions, please reach out to a Nestle representative via telephone or WhatsApp. Do enjoy a fruitful conference. Goodbye.
On October 3, 1948, months after the establishment of a branch of the University of London to serve British colonies, including an extramural department, then the University College of the West Indies, the first campus officially opened in Mona, Jamaica. 10 women and 23 men from across the Caribbean enrolled to study medicine. Later that year, through Royal Charter, the university was formally approved by the Privy Council. It has been rendered as a place of light, liberty, and learning, as well as a Caribbean response to the challenge of change by Sir Philip Sherlock, the first Director of Extramural Studies, and Professor Rex Nettleford, the first UWI alumnus to become Vice-Chancellor in their joint monograph documenting the university's history. 75 years ago, what began as a fledgling university campus in Jamaica has evolved into a future-driven and top-ranked global academy with 5 campuses across the Caribbean and global centers in North and Latin America, Asia, Africa, and Europe.
We are rich in innovations and ideas. We are powerful pelicans, ready to fly on those wings of change like never before.
We are renowned for an exceptional record of producing critical thinkers and leaders who serve the needs of the 21st century society, and at 75, we're just hitting our stride.
UWI's legacy is the light of stellar service and leadership in the Caribbean for 7.5 decades.
A global university rooted in the Caribbean, activist, SDG engaged, climate smart, and championing reparatory justice with a mission to advance learning, create knowledge, and foster innovation for the positive transformation of the Caribbean and the wider world. As we mark our 75th anniversary in 2023, the UWI at 75 Jubilee supports a reflection of our past, homage to the present, and the future outlook.
And so we have to be robust in our management, we have to be strategic in our decision making, and we have to ensure that this university continues to rise and to make proud the people of the Caribbean.
We are rooted. Although our growth and impact continues to be global, we remain strongly influenced by where our university's foundation was built and by our service to Caribbean people and their contributions to the UWI's development. We are ready. We continue to be an advocate for the region, its needs and advancement, and we are recognized as a valuable resource for expertise on every issue that it faces, playing an unprecedented role in enabling the Caribbean's readiness, ability to overcome challenges, to build the Caribbean's resilience, and revitalize Caribbean development. We are rising. we face head-on with realness and honesty the reality that there is still room for the university to grow. We are on a continuous path of improvement and development, and as the light rising from the west, we aspire to rise, to soar higher, and to be a beacon of empowerment to our community. Rooted, ready, rising. Join us for the 75th anniversary of the University of the West Indies. Learn more at www.uwi.edu/75.
The 75th anniversary of the university, 2023, will be a magnificent year.